Videos. The slide okay, hope it is clear.
Okay, very good.
Yeah,
yes, you are audible.
Okay, I haven't started this screen sharing. Screen sharing started.
No. First of all, we will start with our official things. Presidential address and welcome speech. Hi, good morning. Good morning, all the participants. Today we are here for an excellent webinar by Professor Dr. Pradeep Dathan, who is the head of the Department of Sri Shankara Dental College, Agatsumudi, Varkala. And I'm really happy how the things are going on because today we are having 191 participants, 100 participants here in the webinar, and another 91 Sri Shankara students in our YouTube. So I congratulate our faculty, Professor Dr. Pradeep Dathan, who encouraged his students also to this program. When I was a student long back, my professors always taught me how to fabricate a denture or partial denture. Nobody told me how to manage the complications. When after passing my BDS, I joined some clinic long back, and still I can remember that doctor told me, whatever you can learn from me, but I am not doing CDs here. I asked him, why, sir? Why you are not doing CDs here? No, man, complications. The patients will come without any ridge, lower, especially lower ridge and all. I don't want to encourage those patients without ridge in the lower area, and I don't want that money. So I was wondering, then how I will learn the complications. But I really, I'm impressed with the way how Dr. Pradeep Dathan came with the topic, like how to manage the complications. Usually all will teach how to fabricate, how to do beautiful dentures, RPDs and all, but nobody will encourage how to manage the complications. Really, exactly what I'm telling you, really it's a very good topic and a nice topic. And I invite our young and vibrant CD convener, Dr. Adina Chandran, to have a few words. Dr. Adina.
Good morning, everyone. I'm Dr. Adina, PD convener for the Additional branch. I welcome all the participants, especially all seniors from here, and I thank all our office bearers for supporting for this webinar. Shall we go to the?
Thank you, Adina. Thank you very much. So we are going to Professor Dr. Pradeep Dathan, one of our senior most member of Artingal IDA, and we are inviting our faculty for the webinar. Professor Dr. Pradeep Dathan, please.
Okay, thank you, Dr. Sharin, for a brief, nice introduction. Let me take this opportunity to thank the office bearers. Of course, all are my friends. We have been working together since years. So let me take this opportunity to thank all of you for considering me to conduct this program. In fact, I am proud to start a program for IDA in my own branch. I think I was there in the branch since its formation. We all together, Dr. Abhilash, Dr. Biju, I think Anil, all were there. And I think just on the second year I joined, that's what I remember. Anyway, nice to be with you all. And I was an office bearer also, 2-3 posts I have held. And the recent one was the journal editor. And I'm proud to say that the branch could manage to get one award also. So thank you all for the support given to me. Screen sharing will start, Adina?
Yeah.
Can I start with the screen sharing?
Yes, sir. Yes, sir.
Screen sharing. Hello? Hello?
Yes, sir, it's
Hello?
audible.
Yeah, you are audible.
Kanav,
Yeah,
can
I
you
can.
see the screen?
Screen കാണാം.
Yeah.
Okay, I
Audible, and
cannot
the
see.
screen is there. Screen is also seen. She is my professor also, Dr. N. Sulojana Devi. MPS.
Okay. See, I cannot see any one of you. I don't know. Okay. Anyway, I'll start with my presentation.
Please. Yeah.
I
Faculty കാണാൻ
pay my
പറ്റുന്നില്ലല്ലോ.
homage to my professor, Dr. Sulojana Devi. She was my teacher, former professor of prosthodontics in Government Dental College, Trivandrum, and she was there in Rajas Dental College when I joined there for my PG. A tribute to my teacher. And the topic for today's discussion, you all know, it is post-insertion complications related to complete denture fabrication. The name itself implies what complication is happening once we insert, what difficulties we have once we insert, once you deliver the denture. So actually the complications we are creating, that is what my opinion is. We start fabricating the denture, we follow the clinical steps, and we try to start with shortcuts. So there is no shortcut in any of the dental procedure. That is what I believe. So don't go try for shortcuts. Don't create problems within you. We know the complete dentures are given usually for edentulous individuals. Edentulous individuals. Usually for the edentulous people. And once you give, we know from the second day onwards, people start calling us, or on the very next day itself, or that day evening itself, people start calling us. Here, there is pain. And what we do is, I think initially I also used to do like that. We used to avoid those people, telling them that these are new artificial things which is kept into your mouth. It will take some time to adjust. So you please bear with it for a few days. Like that we used to tell. But later on, I understood that that is not the real way to approach a patient who has received a new denture. Because edentulous people, they have a lot of other stress in their life. And according to statistics, if you see, World Health Organization has estimated that the prevalence of edentulism in India in age group of 65 to 74 is around 19%. 19% of the people are edentulous in India. I remember when I go back to my graduation days, I remember that my teachers telling us that the percentage of edentulism is going to come down in the coming decade. That means once we reach the 2000 or 2010,
Class.
like that, this percentage is going to come down.
എനിക്ക് അപ്ഡേറ്റ് ചെയ്തല്ലേ പറ്റൂ.
Somebody is talking in between, and this percentage is going to come down. But what we see is the number of edentulous people keep on increasing, or at least it is maintaining the percentage. Because in 1990s or late 80s, when we were doing a graduation, that time it was told that by 2020 the percentage of edentulous people is almost going to be very less. But later on in 2018 and 19, when the studies were conducted, that it was evident that there was no decrease in the percentage of edentulism, but in fact it has maintained or it has shown a slight increase. The main reason behind that is nowadays the life expectancy of people have gone up. Previously, the life expectancy what we had was around 60 to 65 years. Now it has gone to 80, 85 years like that. So as the people grow old, the tendency of becoming edentulousness has also increased. So the percentage of edentulous people has been maintained mainly because of the increase in the aging population. Okay, the aging population, that means the people above 65, 70, 80, 85 like that, they have increased. That is why the edentulism has not come down. This is the statistics that they give. In 2015, around 65, around 8.5% of the total world population above 65 was present. And by 2030, the people aged above 65 is expected to grow by around 60%, not to 60%, but from 8.5, a 60% increase will be there. That means from 8.5, it can go up to 13, 14 like that. And in the world, by 2050, the people aged 65 is going to increase by 16.7%. Means old age people aged above 65 will be 16.7%. And 2/3 of this population will be in the Asian region. In the world, 2/3 of the aged population will be in the Asian region, and that too we should be proud. It will be in India and China. India and China. We both will be sharing the old age group. Majority of the old age group will be in India and China. So as the study says, as the percentage of, as the old age increases, edentulism also increases. By 75 to 84 years, around 29% will be edentulous, and over 85 years, around 45% of people will be edentulous for considerable amount of time. So what has happened is, in the previous years or in 80s and 90s, if we were treating relatively young edentulous people, but presently we have to treat much more older one, which is going to be more and more difficult. Treating a little bit young age and treating old age both varies. See, by 85, almost 85, 90, almost people will be like this. I think he is around, this particular person is around 104 or so. That is what I saw in the net. And we know the fabrication of complete denture has some clinical and laboratory procedures, and it is a technically demanding. It needs some skill, and also it needs regular follow-up. This is mainly because complete dentures or artificial dentures, what we give, mainly differ from the natural teeth in both its form, function, and appearance. The complete denture has to be in harmony with the oral environment what we are going to treat. The ridge should feel that I should have a complete denture. I should have that denture. Why that happens is mainly because after extraction, once the patient is edentulous, we have learned that ridge undergoes continuous change. So the tissues, both the hard and soft tissue, undergo changes in due course of time, and dentures what we give also undergo constant change. The teeth may wear off, some cracks may develop like that. The dentures also undergo tremendous change. Hence, complaints are bound to happen. If complete dentures are fabricated to be on a cast like this, it is not going to harm us. It is not going to harm anyone. In front of your table, if you have a complete denture, a well-polished complete denture, you can also have a look, have a smile. Okay, it's not going to hurt the cast. It is not going to hurt you. But complete dentures are not fabricated for this purpose. It is fabricated to be within the mouth. It is fabricated to be within the mouth, and if it merges with the oral cavity, you can have a patient with a satisfied smile. We know the mode by which the natural teeth is attached to the jaws and the method by which the dentures process differs. Natural teeth, definitely it has anchored to the bone. It is attached to the bone to the periodontal ligament. It is slightly mobile. That means the periodontal ligament will give a cushioning effect once load is being placed. But whereas the complete denture rests on the soft mucosa. And always the mucosa is trapped between a hard denture and a rigid denture and the hard bone. So two hard structures in between, a soft structure is being sandwiched. So in Malayalam we say Chagathanum Kadalinu Idayil, between the devil and sea, like that. So if the tissues are not maintained to its original health, then it is prone to get injured. So this always you have to keep it in mind. So as I told you, it is a technically demanding, it needs more skill for its fabrication. But what happens is teaching in complete dentures have decreased over years. Gradually it has decreased. The amount of time spent for the undergraduate coaching for complete denture or undergraduate training for the complete dentures have come down. That is mainly because the advancements in each field. In prosthetics itself, a lot of other treatment modalities have come. In Denture, they started preserving the teeth. Perio, all advanced surgeries has come for maintaining. So in each field, students need training. In olden days, only extraction and replacement was considered as dental treatment. Nowadays, lot of other treatments have come. So the time spent for training in complete dentures have come down, and the attitude of the trainee and the trainer has changed. That also has happened because complete denture, you need little hard work. Once the patient goes out of your clinic, your work starts. The laboratory works has to be carried out. All other departments, they can close and go, but never a prosto UG student or a PG student or a working staff can go back. That is the situation. So people are also a little lazy to do the things. So naturally the training goes wrong. So goes a little less. So a undergraduate student who is coming out hardly makes 2 or 3 dentures. That is the present scenario. Long back during our time, around 15, 16, 17, 18, 20, like that we used to make with the 2 years, the third year and final year. And then plus house agency, we will get 1 more year. But presently, hardly an undergraduate student will be doing around 3 to 4 dentures. Maximum, that is the maximum. And from the last 2 years, we know what is happening because of this corona. So definitely difficult cases like resolved mandibular ridges, it's a challenge for them. Naturally, they have to take help from others. It is good if they take help from a trained or help from a professional. Many times what happens is they go in some other way. They go for shortcuts. Some auxiliaries, they take the help, and gradually the complete denture fabrication shifts from the dentist to the other side. That is really a pathetic situation. I hope, I wish all the dentists should be trained at least in making a good complete denture. You know about how the mandibular ridge resolves? Atwood has given that classification. So these 3 varieties, the 4, 5, and 6 is really difficult to manage because here almost our neurovascular bundle will come up and it will be very difficult to give a denture over here. So like these cases, if you want to treat, really you have to be skilled in your work. That skilled means tremendous, continuous training is needed. That is why usually we introduce quota system. You do this much denture. And nowadays people take it as an imposition. We introduce the quota system just to gain the experience. Sivkumar Jayachandran in Birmingham Dental Hospital, UK, he has conducted a study to find out the reasons why these complete denture patients are referred to higher centers or secondary centers. And he found that difficulty in managing the resolved drawer ridge was around 39%. Many other reasons, difficulty in swallowing, difficulty in speech, all those things was around 28%. Looseness was around 25%. Pain was around 11%. Difficulty in managing immediate dentures were 8%. Gag reflex was around 7%. And for placement of implants was around 7%. Altogether, it will become more than 100%. Why? Because the individual which they have analyzed had multiple complaints. That is why if you add all this together, it will come more than 100. That is mainly because different same people had 2 or 3 complaints together. So the common complaint what we see over here is mainly looseness and pain. Looseness and pain. Then it is followed by faulty aesthetics, inefficiency, mainly inability to chew, all those things, and then mostly gagging. Looseness and pain is the main thing. So whenever the patient come back to you telling some complaints, just listen to them carefully, spend some time to what they're telling. Don't just be reluctant. Don't just tell them that this is a new one. It will take time and nothing is going to happen. You do not need any adjustments like that. And I don't just listen to them. Just listen to them. Spend some time with them. Then examine if some adjustments are required. Then do that. Carry out. If you listen to them and if you assure them that the dentures will be okay within one or two visits, definitely that is going to work. And one more thing, you have to start educating the patient from the beginning. On the first day when you do the diagnosis, that day itself, you have to start educating them. You tell them regarding the limitations of the complete denture. You tell them how the upper dentures are retentive. You tell them how the lower dentures will be less retentive. You just ask them to compare themselves regarding the area available for placing the dentures, and make them understand that mandibular dentures will be stable only by their ability. That means mainly by the variance created by the cheeks, the lip, and the tongue. So you have to fabricate a stable mandibular denture by placing it in the correct area. Once that is correct, the mandibular denture will stay. Definitely, you are not going to get a peripheral seal like you get in a maxillary denture. There are limitations. So the first complaint, I hope it is audible and visible. Hello?
Yes, sir. Audible and visible. Yes.
Okay. Because I cannot see anyone in my screen. That's why I'm asking in between. Can you see me?
We can't see you, but the slides are well audible, and we can see the slides also.
Okay, thank you. So the first complaint in complete denture fabrication, what we are going to address is the looseness. Looseness is mainly because of the poor adaptation to the denture bearing area. And 40% of the failing dentures are because of this. Once the denture is not going to adapt to the underlying denture bearing area, there will be a rocking movement of the denture, which affects the stability. This is mainly occurs due to an error. It mainly occurs due to an error during the impression procedure. You can see many times when you remove an impression, you will see one void like this. You can see a map of an India or China or whatever it is, Sri Lanka or whatever it is. So these voids are mainly created by entrapment of air, within the tray. Once you load the tray, there will be some air pockets, and that air fails to escape while you are compressing the tray towards the tissue. So this can be avoided by putting vents. Vents means holes. This can be avoided by putting vents. These vents are also called as relief vents. These vents allow the excess material as well as the trapped air to come out through. So that will escape through the excess material as well as the trapped air will escape through these vents. That is why those vents are important. And also you can record those tissue in a relieved manner. Okay, that is the function of those vents. So once you vent the impression properly, this air entrapment can be avoided. Once, if you have a large void like this, definitely don't try to repair. Once you try to repair, what happens is you'll be keeping the material over here, and you will be compressing it again. You will be placing it again in the oral cavity. What happens is once it is compressed, excess material will flow over here. Actually, these all areas has already been well recorded. When the excess material comes, there will be additional thickness. In the cast, there will be a small depression which we will not notice. Definitely, when you occlusize, the denture will be there, and then the starts rocking. This is a common thing. What happens? So once if the void is large, just eliminate the impression. If the void is small, If it is 2 millimeter, 3 millimeter, you can 3 millimeter size void, you can forget regarding that. You need not do any correction. You can pour the cast directly and just maybe that cast you can just scrape away that little excess what is left. Or else if you won't scrape also, nothing is going to happen. But larger voids, never try to repair, try to repeat the impression. That is what we have to say. And the placement of vents also differs according to the material what you choose. Many people are using zinc oxide digenol, still using zinc oxide digenol as a final impression material, and many are using light body as a final impression material. The thing with zinc oxide is a highly viscous material. Zinc oxide is a viscous material. So 2 or 3 vents are needed in for if you are using zinc oxide as a final impression material. Whereas light body elastoma is a free flowing material. If you put 2-3 vents, the entire material itself will flow out through these vents, and finally there won't be much material for recording the details. So for light body, you may place just 1 vent at near the incisive papilla region or just behind the handle. That is what we say. And it's a common practice to make a single impression. Why the dentures won't adapt properly? It's a common practice to use a single impression for fabrication of complete denture. And that too, the single impressions will be made by Alginate. I'm not against Alginate. What I'm telling is, Alginate, if it has to give a good impression, Alginate definitely has to be properly supported when impressions are being made. The trays what we are using for making the primary impressions are usually our stock trays, which definitely won't properly adapt to the oral tissues. And moreover, in severely resorbed cases, Alginate fails to record the details. If at all, if you are using Alginate for a primary impression, you have to use a very thick mix. Don't use a loose mix. And always follow this 2-stage impression, the primary impression as well as the secondary impression. And the primary impression may be made with a muco-displacing material like putty, or you can even use impression compound also. But try to use newer materials like silicon putty. That will be better. And use a secondary, a custom tray or a secondary tray for making the final impression. This is just a picture. And it shows here, it shows a stock tray which is available. You see the flanges, how the flanges look, it almost stand outward like this. Once you place it in the patient's mouth, you see where the tray borders stands. The tissue is over here. You have to record this sulcus and the tray is standing here. And usually, generally, we use the tray like this. But if you modify this tray a bit, the stock tray itself, if you modify and use, it will give a much better result. This is what we can do. You modify the tray by bending. See, this side I have not done anything. This side, I have just bended the tray and I have adapted it towards the tissue. Both the sides we have done. You see how the tray is over here and how it is over here. See the difference. So you should not be hesitant to modify the stock tray what you have, provided you should have the mind to do that. Usually this stock tray is what we have. We would like to transfer it to the other generation. Like that we use. Malayalam we say, we have to hand it over to our, if my son is studying, I will hand it over the tray to him, then he can make a denture. Like that we think. Don't think like that. Have a number of trays. Have different sets of trays. Try modify those trays. You can bend it and modify. Sometimes when you bend it, this tray flanges may be touching here. If the height is more, trim it off. Use a nice dental lathe and trim it off. If you are trimming, then modify those borders by sandpapering or smoothing, whatever it is. So see the difference, how the stock tray looks in the beginning and how it looks after modifying. Definitely, any person can tell the impression made with this tray and impression made with this tray varies. Actually, it is the same tray with a minor adjustment. We will be getting a much better impression. So next, you can go ahead with your impression material, whatever you're using. If you are using a putty material, you can apply the adhesive and go ahead in this fashion itself. But if you're using alginate, you need to modify the tray a bit. You have to, the posteriorly, if it is not properly extended up to the hamlet or not, you have to extend the tray posteriorly with acrylic or modeling compound. If you are using silicone putty, better to extend the tray with acrylic. Or if you are using alginate, extend the tray with your modeling wax. And borders of those tray has to be beaded. Just give a small beading on all over the borders. See, the maxillary and mandibular tray has been beaded. Then you can go ahead with your alginate impressions. This is an alginate impression made with alginate. This is a primary impression made with alginate, and this is a primary impression made with putty. You can see the well-rounded borders. Here also you have rounded borders just because you have support from this particular modeling wax which you are given at the borders. And always when you make an impression, there will be some excess material which is flowing out at the posterior aspect. And for the mandibular, you have the little impression material which is much raised at the heels, and this is going to trouble you during pouring. Usually, we take this impression to our lab, and we will keep it on the lab table like this. The posterior borders will be touching the table. Once you mix and come, there are every chance that the impression may get detached from the tray. The impression may get detached from the tray, and without knowing, you will be pouring and you will be getting a distorted cast. So to avoid that, just support the impression on the tray surface. Just support the impression where the tray is present. You can use anything for support. You need not construct a special thing for that. Actually, these supports are just bottle caps. You just supported it, and then go ahead with pouring. Then, of course, once you get a good primary cast, you have to fabricate a special tray, and then go ahead for the final impression. Final impression, when you make, do the border molding in a proper way, such that you record the depth and width of the sulcus during function. So the functional depth and width of the sulcus has to be recorded. Then after recording, this has to be transferred to the cast. Just simply recording won't do. That sulcus depth and height has to be present in the cast. For that, you can, if you are pouring by the impression of your own, just mark the borders. If you are pouring or if you are giving to a technician also, just mark the borders around 2 to 4 millimeter away from the border. You just put a mark, and make sure that when you pour, the stone will overlap at least up to here. The stone will overlap at least up to here, because these areas you have molded, the reflection of the cheeks and the lips, these areas you have molded. This you have to duplicate in the cast. Either you mark it and you pour it yourself, or you mark it and tell the technician that when he pours, it has to be up to here. When he is pouring the impression, the pour should come up to here. Or do a beading. This is done with plaster. This beading is done with plaster. Just apply a coat of separating media, do the waxing, and then pour the cast. Finally, you'll get a secondary cast like this. See here, the adequate depth of the sulcus has been copied. See, the sides which you have molded has been copied over here. The land area of the cast. For the mandible, the tongue space is kept smooth. The land area, the sulcus depth and width. So this is the reflection of the cheeks and lips, what you see over here, around 2 to 4 millimeter high it will be. So altogether, the cast will be having a thick base, the land area, and the impression surface. In cross section, if you see, this should be the base height of around 15 to 16 millimeter. Actually, the base provides the rigidity to the cast. The base provides rigidity to the cast. So that has to be done. You have to make the base also. This is the land area, width of around 2 to 4 millimeter. Is usually from that beading thickness, you get this land area, and this is what we get the height of the sulcus around 2 to 4 millimeter. Once this height is there, definitely the width also will be copied. So you will be fabricating a denture with a flange border of this much thickness. See, the mandibular tongue space will be very small. The base will provide the rigidity. Unfortunately, if you visit a lab, you can see the secondary cast like this. You are murdering the prosthodontic procedures. This is an unfortunate thing. No base, no proper sulcus depth, no proper width, no details, only the ridge we have. The maxillary and the mandibular. Previously, we used to see such things. I don't know. Now, I think because of this CDs, people are more aware and they won't be doing such cases. It will be done by some auxiliaries. I think generally dentists nowadays, they won't do this. That is what I feel. Another area where we can go wrong is for the poor adaptation is regarding the flasking procedure. So usually, I told you this cast you keep in mind. Usually such type cast goes for investing. See, investing has to be done like this. See, the land area from here, the plaster is sloping towards the periphery, and the entire rim of the flask is exposed. Once you expose the entire ring, you have to apply the separating media. You'll be putting the second compartment. So the metallic portion of the second compartment will be in intimate contact with this rim. And then you pour the remaining area. After dewaxing, you will get it like this. See, the first compartment, nice rim of that flask. The second compartment, after dewaxing, the rim of the flask is visible. So when you close, the flask rims will be contacting each other. There will be passive contact of the denture mold. The plaster or the stone, whatever you are used for preparing the mold, will be having a passive contact between the two chambers. Usually what we do, once you do the flasking, the entire flask will be covered with the plaster. If possible, we will close these two holes also. Actually, these two holes are meant for this particular metallic projection to go into. We try to close that also. We pour plaster all over and then put the second compartment. It will be 2 to 3 millimeter away. And then we pour the plaster. There won't be any contact of the metallic component of the flask. And you do dewaxing and remove. The plaster from the rim borders will break off. And then you do a packing. The entire stress what you apply for packing will come onto this plaster. This both mold will come onto this mold. And if the plaster is little weak, it will fracture. Once it fractures, there may be some slight change in the movement. Or if you are giving a cast, as I showed you, like this cast, the cat's cast itself can break. That also can cause distortion of the denture base. See here, that won't happen because when you close, these metallic portions are going to come in contact. The excess material flow out. The metallic portions of the flask are coming to contact, and undue pressure won't develop within the mold. At the same time, because of the pressure applied on the flask, the excess material will come out. So flasking also carries a lot of importance, because many times we have seen that in the clinic, after trial, your dentures were perfect. It was seating, had adequate retention, no rocking movement, nothing. But once after the final processing, once you try to put it in the patient's mouth, the denture starts rocking. There, mainly the villain is this: the flasking procedure. We might not have done properly. That is the thing. Next, the second cause for looseness is so all those things will reduce the adaptation of the denture base to the denture bearing area. Definitely, the dentures will be loose. Next is regarding the inappropriate extension of the denture borders. So denture borders can be overextended or underextended. An overextended denture can be retentive. The overextended denture can be retentive. But when the patient starts his function, or when the patient sits in rest, the denture will unseat from the denture bearing area. Because suppose this is the functional depth, that means during speech or at rest, if this is the depth of the sulcus, this has to be recorded. That is why we do different movements for the lips, cheeks, and all. And all those movements should be done in a limited way, not in an exaggerated movement. That what we do for the label aspect, we usually pull the upper lip a bit down and in. For the buccal aspect, we push the cheek a little bit out and down, maybe a little forward and backward. Instead of that, people usually do cyclic movement. Just push the cheek, push it out, push it in, push it forward, push it backward. By the time the patient finishes his final impression procedure or the bottom molding procedure, you can see if the patient is very fair, you can see the cheeks becoming red. Like that movements you are not supposed to do. We are handling not a phantom head. We are handling a patient, a live patient. He also has the flesh and bone what you have. Give that consideration. Give that humanitarian consideration. Don't push and pull. Just do a gentle movement for the tissue. Then you get the functional molding. So you have to get the functional depth and width of the sulcus. If you are getting that, definitely you will get the peripheral seal. So the functional depth has to be recorded to get the peripheral seal, especially for the maxilla. How this peripheral seal is obtained? See, this is the reflection of the cheek which is coming down. So around 2 to 3 millimeter from the denture border, it has to extend. This will be reflected in the cast. That is what I told you how to pour the cast. So when you place the denture or when you seat the denture in the patient's mouth, there will be a thin film of saliva all around the denture, from this border to the inner fitting surface and then to the other side. It will be a thin film all around the denture bearing area. So this thin film will come out, and here the cheek is there. It will form a meniscus over there. So if you're recording the functional depth, the sulcus won't be disturbing the denture. It will stay there, and gradually during function, the denture will retain in place. And this retention is mainly by the cohesion, adhesion, surface tension caused by the saliva. And that is maintained by the peripheral seal, what we obtained by molding. That is maintained by the peripheral seal, what we obtain. Peripheral seal, how we will make is by proper border molding. Each movements you have to duplicate. The functional movements of the patient you have to duplicate. That is why do gentle movements. Even for the mandibular, when you ask them to move the tongue, the movement should be gentle, not rapid. So if the functional depth has not been recorded, what happens if you are overextending during function? The sulcus will return to its original depth. Gradually, it will dislodge the denture. It will unseat the denture from its place. A slight unseating, air will enter, and the entire seal will be lost. I think in our dental materials class we have studied regarding surface tension, how to stick two glass plates together by putting a drop of water. To try to separate it, it will be very difficult to separate. Try a small gap through which the air enters, definitely it will get separated. The same thing applies over here. Once it moves, air enters and it will come down. See, this is the meniscus what is being formed, and this is a enlarged version. So meniscus what is formed, and this meniscus will be salivary thin film of saliva will be continuous throughout the denture bearing area, and that gives adhesion. See how the flanges should be. Just a diagrammatic representation. Should fulfill the thickness as well as the height of the denture bearing of the ridge. Oh, sorry, of the sulcus. Over extensions, which all area commonly it occurs. The anterior region, buccal flange of both upper and lower dentures, the lingual areas, the distal lingual region of the lowers, all these regions, there can be overextensions. These overextensions can be limited or can be minimized or can be avoided by giving a proper movement, functional movement. To ask the patient himself to move his tongue. And always the movement should be restricted. If you are moving the cheek, if you are moving the lips, do a slow movement. Use a good border molding material. Silicone putty can be used. Only thing, the consistency you have to adjust by adding a little bit of petroleum jelly or Vaseline, whatever it is. The viscosity can be adjusted. So use a proper material, use proper technique, you definitely will get a very good border extension. Under extension do occur in the posteriors of the mandibular, the lingual, distolingual region, then the anterior buccal flange, all these areas under extensions can happen. And this is what we see. The borders of the denture, you have a lot of structures. We have the muscle, the frenum, the bony encroachment from the mandible, the bony encroachment from the maxilla. All these were there in the patient's mouth. It is not that when we are going to denture, when you are going to fabricate a denture, suddenly these things appear. These things are already there. They were functioning. Just because we are giving a denture, we should not be adamant that these things should not function. We cannot say like that. You should, your dentures should be there by allowing all these structures to function. Then only your denture will be success. These are the limiting structures we say. The frenum, the muscle, the bone. This is the zygomatic process. This is the coronoid process, whatever it is. All these things has to be kept in mind and do the concerned movement and record it. So the frenum and the muscle, it affects the denture retention. Since they are present at the periphery of the denture, if you encroach to that to their region, definitely it is not going to permit those encroachments. Let them do their function. The dentures should be in harmony with that, but not troubling them. So how will you do that? Check the tray. See, the main step is the impression. The main step is impression. Next is the jaw relation. I'll tell you. The main step in denture success is an impression. If you make a good impression with a good material, with proper technique, your denture will be success. If you compare the comfort of a denture made from a putty impression, and if you compare the comfort of a denture made from a single digital impression, definitely it varies. Upgrade yourself to the silicone material. Nowadays, the digital impressions have also come. I don't say you do that, but at least upgrade yourself to the silicone impression materials. So the remaining all procedures are same. Making the mold, making the custom tray, making the custom tray, all those things. So what you have to see is you make the custom tray, you place it in the patient's mouth and see for the clearance. Here you see the label surface have got adequate clearance from the sulcus depth, and there should be at least 2 to 3 millimeters space between the tray border and the tissue, and that space is for the border molding material to work out or to mold the borders. So always for checking, place the tray. The anterior region, you just reflect the lip in a downward and outward direction. Downward and outward direction. Don't lift it. Once you lift it, you won't know whether your extension is correct or not. Just downward and reflect, and just see from below. If there is a gap between, or if there is a distance between the tray border and the reflection, it is good. If it is not there, make that reflection. Here you can see this region, you have adequate relief for the frenum, but here there is no, because the tray is contacting. Here you have to modify. Label sulcus has got adequate relief, but not the buccal sulcus. See how intimately it is contacting. Buccal also, little outward and downward, you reflect and see. Usually a properly trimmed or a properly adjusted final impression tray or the secondary tray, once you keep it in the patient's mouth, and when you do the functional movements or when you do the reflection of the lips and cheeks, the tray will stay in patient's mouth. You do the movements, the tray will stay there because it is not touching the what do you say, that border areas. It is not touching the limiting structures. So the tray is going to, will stay there. We cannot say it is retentive, the tray will stay there. Then you place a border molding material, preferably silicone putty, which is adjusted to its consistency. Add a little bit of Vaseline, adjust its consistency, mix both the base, place it at the borders, and if you do a proper molding, not exaggerated molding, if you do a proper molding, you'll get a well-rounded border molded area. Molding at the mandibular impression, another critical thing, another difficult thing what we come across. The buccal side is always easy. You just place the border molding material, pull the lip up, pull the cheek up, all those things you will get very clearly. So what is going to be a headache is regarding the lingual. So once you place the border molding material at the distal lingual region, imagine you are keeping it on to the right side of the distal lingual region. Okay, then place the tray in the patient's mouth and ask the patient to move the tongue to the opposite side. A gentle movement of tongue to the opposite side. Maximum up to the tongue tip. The tongue tip should touch the cheek. The tip of the tongue should touch the cheek. Nothing more. You should not ask him to take the tongue so long that it perforates the cheeks and come outside. No, just touch the tongue with the cheek, touch the cheek with the tongue. Because maximum movement, what we do is, you with your tongue, you may collect the food which has been lodged in the buccal sulcus with your tongue. You may collect the food which has been stuck in the buccal sulcus with your tongue. That is what do. So right side you do like that. Do the tongue movement in a gentle way. Definitely it will mold. Exaggerated movement, what happens is the tongue will displace the impression material. It won't mold. The tongue will displace the impression material. Another area where we find difficult is the lingual frenum. Ask the patient to raise the tongue and touch the palate. Press it against the palate, anterior aspect. Anterior premaxillary region, you just ask him to touch, or the rugae region, you just ask him to touch and press. The mouth is open, ask him to elevate the tongue, touch the maxilla and press against it. Or ask him to protrude the tongue only up to the border of the lower lip, vermilion border of the lower lip. Or he can wipe the lower lip also. But usually what we say, we ask them to protrude. The patient may protrude the tongue in such a way that he will lick your pocket. In such a fashion, we are asking the patient to protrude the tongue. The protrusion, all the movements, what is to be carried out should be a gentle one. Definitely, the patient will mold the borders for you. You need not struggle. The patient will do it for you. So all the movements for the border molding has to be very much limited, very much precise, no exaggeration and no speed. Like that you have to do. But you have to keep in mind that the impression material will set. Within the setting period of the setting time of that impression material, you have to do this. But if you get it much better if you do slower movements. Next is, once you fabricate all this, once you get an impression, once you construct the denture, you see the frenums are not that is copied to the denture. That happens. The next thing what you have to do is, you have to, once you get the denture, you have to relieve the frenum. Buccal frenum, we will just have a depression over there. When you get the finished denture, you have to extend it. For the buccal frenum, the extension will be very thin. A thin extension, because the buccal frenum is very thin. So that frenum should come and sit into this frenal node. Sometimes it will be very deep. Extend it all along. After extending with a proper burr, what you have to do is, you have to round off the external angle as well as the internal angle. Otherwise, these sharp edges will hurt the frenum. So that has to be rounded. Once the denture accommodates the frenum won't unseat the denture. If you won't round off these angles, again the patient will come and complain to you regarding pain at the root of the nose. At the root of the nose. That is the common complaint. If you won't relieve the frenum properly. Buccal frenum, here the angles are getting rounded off. The buccal frenum actually is quite wide, fan shaped, we say. It's quite wide. It has got some anterior and posterior movement. So you have to give a broader frenum for the buccal aspect. See, it is broad. So you have to relieve the denture borders in much more broad broader area of relief has to be provided. See here, the buccal frenum is a little bit broad. The relief for the buccal frenum is a little bit broad, but here it is thick. That is mainly because how the frenum is being attached. The labial frenum attachment is thin. The buccal frenum attachment is wide. Next is regarding the posterior extension of the dentures. We don't know where to stop. We make the impression of the esophagus also. Usually that happens. Luckily, God has given that gag reflex so that we know that we are not going too much in. We should know where to limit the dentures. See, this is the posterior limit what we see. Here, this is the bone. This is the ridge mucosa from the soft palate. It starts over here. This is a enlarged version. The bone is coming, the palatal process is coming, then the spine, the hard palate is coming and ending here, and the soft palate actually overlaps the hard palate. The soft palate actually overlaps the hard palate. So actually in this region, there is a bit of bony support. So at this region, you can compress the tissues. You can compress the tissue. Compression is possible because of the presence of bone. You can compress the tissue, and those areas are called as the posterior palatal seal. And by definition itself, it says that area can be compressed, but you cannot compress this area because there is no bone. You can only displace it. Here, the soft palate overlaps the posterior most border of the hard palate. Then those area you can compress. We say see, this is the picture what we have. Then a very good picture I got. See, this is the palatal process. This is the spine. See here, the soft palate starts. Hard palate is almost coming and ending here, and here the soft palate starts. So the soft palate actually overlaps the bone, which is present over here. So in this region, you can compress. Soft palate is extending like this. So in this region, you can compress. There is bone over here. That is why compression is possible. Whereas this region, you cannot compress. You can only displace. That is why this portion is called as a posterior palatal seal region, where you can compress and you can get a seal. Peripheries, why you get a seal is there because there you can compress the tissue towards the bone at the peripheries, denture peripheries. Here also with the denture border, you can compress the tissue and you will get a seal. That is the posterior palatal seal region. Definitely, by definition, I think we all remember tissues can be displaced to its compressed to its physiological limit. That is what. And the dentures, we say it has to extend up to the posterior vibrating line. Another difficult thing to locate. Locating the hamular, definitely the posterior palatal seal extends from one hamular notch to the other. You know, or you all know. So locate the hamular notch using the head of a mouth mirror, or you can use even the T burnisher. Okay, locate that. And always the posterior palatal seal connects these two hamular notches. So here, once you mark the hamular notch, then you ask the patient to say ha in a short thrust. Ha, ha. You just ask him to say. Definitely the palate will come down and go up. Just notice the movement of the palate. At one area, the movement will end. Don't see for minimum movement, medium movement, all those things. In textbook, they are mentioned like that, minimum movement. At one stage, the movement will end. You just mark that region. Just draw a line through that region, connecting both the hamular notch. That will be the posterior vibrating line. The palatine aponeurosis and muscles forms this, because all the soft palate muscles will come and attach over there. Detailed anatomy, don't ask me, but it is something like that. The palatine aponeurosis is present over here, and that is why you get that immovable structure that during when the patient says "ha," the movement will come and end at that portion. So mark it. Just check whether your tray is extending up to that, and anterior to that. If you see anterior to the posterior vibrating line, you will get an area of displaceable tissue. Here I can see. I don't know whether what you can see this area. Or one thing what you can do is you can use a little finger. You can use a little finger and just palpate anterior to that. You will feel that some areas you can press the tissues. A little finger means the finger has to be little. Okay, the person has to be a gigantic person's little finger and someone else's little finger will vary. Okay, so a person like me who's quite fatty, the finger also varies. So I cannot say my little finger according to your own dimension you take. Anyway, or you can use the head of your mouth, handle of your mouth mirror, the most end, terminal end of your mouth mirror. You just do, and even that instrument, that tea burnisher, ball head of the tea burnisher can be used. That area is very less. That ball head has got a very little area. That is why I'm not insisting on that. You can use the handle, the terminal end of your handle of your mouth mirror. Don't hurt him. Just gently you see some areas it can be displaced and you mark it. And then just check almost here like this. I can make out. So just make sure that your tray extends up to here, and while making the impression, you place the border molding material over there, seat it, and gently press with your fingers over here. A tray, that tray you have to gently press. So you'll be displacing, or you'll be compressing, not displacing, you'll be compressing the tissues which is present. Definitely when you take out the impression, you can see a slight elevated portion at the posterior aspect. That will be the posterior vibrating line. Once you compress and once you do the functional molding, don't allow the technician to score the posterior aspect, because already you have compressed the tissues and you have made the impression. Technician, according to his own technique, he will score this area and he will tell us, I have created the post dam. But if you are making an impression like this by applying pressure at the posterior palatal seal, never allow the technician to score those regions, because your denture fails, because already the tissues are compressed. In addition, their damming causes excess compression, tissue rebound will occur, and the dentures will unseat. So always, if you are taking a good impression with proper recording of the posterior palatal seal, don't tell the technician to do the post damming or the arbitrary scraping they do, and they tell all those names. Post damming we have done, that will add all those things there. Don't go for that. So these are different 3 types of soft palate that we have. The type C will have an acute joint with the hard palate. So the area available for the posterior palatal seal will be limited. This and all, you know. Then regarding the extensions, where we have to take be careful for the mandibular dentures, where we have to be careful is this. Usually we say this region, the retromolar pad. It's a very small area, but has a lot of importance. The retromolar region. Whether the denture has to cover the retromolar region or not. Whether the denture has to be extended to the retromolar region or not. If possible, you extend the denture up to the retromolar pad. There is no wrong. You should cover the retromolar pad. What many claim is that retromolar pad, since it is a compressible tissue, you are able to get some certain amount of seal over there. I'm going to do like that. One argument is there. Okay. Whether to extend it or not is questionable. You see this condition. The retromolar pads are located very high, and see how the heels of this mandibular denture is. Here, just a 1 or 2 millimeter gap. Here it is touching. Here it is touching. The lower heels are touching the upper denture. If you are going to give a denture like this to the patient, definitely the patient will tell you the dentures are touching at the posterior aspect. They may not tell like that. They will tell you while moving, the dentures are getting dislodged. I am not able to approximate the denture properly. While moving, it is going to, because the mucosa is resilient. Such cases also, once it is seated, because of the resiliency of the mucosa, this will be touching, the lower heels will be touching the upper denture. So whether to cover or not is questionable. That is what I told you. If the case is like this, if the retromolar pad is very high, And if the patient is going to have a steep flange like this, this is not going to permit the lateral movements or excursive movements, because once the patient do those, the lower heel will be touching the posterior border of the upper dentures. So in such cases, don't hesitate to cut off the denture. You can cut it off up to the anterior two-thirds. Anterior tetramolar pad, if you're dividing it into three, cut it off up to the anterior two-thirds. Again, if you feel that it is not required, it is not giving adequate thing what you need, again you can reduce it off. You can remove it off also. It is not going to create much harm as expected, because many claim that there is a claim that retromolar pad, because of its compressibility, it gives a seal, but the area you see is very limited. So that much seal loss is not going to disturb the mandibular denture. Why, we will see in between. Okay. Another thing is regarding the modulus. That is, this is coming later. The flange has to be adjusted for the contraction of the modulus also. That will come later. So this, you don't hesitate. The lower denture, if it can be extended, okay, you extend, well and good. If you cannot, don't try to extend. Definitely, the retromolar pad has to be copied in the impression. That is for no doubt. In cast, it should be there. That is for no doubt, because it determines. It's a guide for determining many things, especially the occlusal plane. It's a guide for determining. Another neglected area for the mandibular way, which causes mandibular denture and causes the unseating of the denture, is the distobuccal region, which is associated with two muscles. One is mainly the masseter, where the masseter is, and next to the vaccinator. Both comes in opposite direction, one in a vertical and one in a horizontal fashion. So always this contraction of the masseter is going to affect the movement. It will activate this vaccinator also, and it is going to affect the distobuccal flange of the lower denture. So the distobuccal flange has to be molded. So how will you mold? You place the border molding material, preferably the silicone putty, seat it, ask him to close, ask the patient to close and resist closure. Okay, just gentle pressure to activate muscle. The pressure should not go very high. The mandible will come out. Don't pull the mandible out. Just ask him to close and resist that closure. So the masseter will get activated and the impression will mold. Otherwise, what happens is, when the patient do the opening movements or when the patient tries to clench, either the denture will unseat or an ulceration will be formed at this region. So that has to be very precisely done. Next is regarding the occlusal plane, how it affects the denture retention, or how it is going to affect the how it loosens the denture, that we will see. This determining the occlusal plane, everyone knows. During the jaw relation period, we do. During the jaw relation period, what we do is anteriorly, the occlusal plane, we keep it parallel to the interpupillary line, and the occlusal rims, we keep it at the level of the upper lip. Preferably for our population, we see, especially in Kerala, we have to keep it at the level of the upper lip. Why? Because most of the edentulous patients, when they come and sit, we won't realize that the patient has come for a complete denture. We won't realize, because their lips will be properly supported, mainly because of the prominence of the premaxilla. The lips will be very well supported. We won't be knowing that they are edentulous. Once they open the mouth, and when you examine, that time only you will find that they are edentulous. So you have to better just to keep the occlusal plane at the level of the upper lip, the anterior, and it has to be parallel to the interpupillary line. That is how we adjust the anterior occlusal plane. Posteriorly, again we go for the ala tragus. This sound is very glass. Posteriorly, we go for the ala tragus, the point from the root of the nose, the ala of the nose, to the tragus. So the tragus, at the ear, the anterior border here. Take the posteriormost point of the tragus. Tragus is almost a pyramidal shape or a triangular shape, whatever it is. So the posteriormost portion, if you take, that will be good. Again, people say you have to take the superior aspect of the tragus, the middle, the inferior, like that. As age advances, you go high, you go low. Hardly 1 or 2 millimeter difference is there, so you forget. At least identify. It is easy to identify the posteriormost point of the tragus, extend and make the occlusal rim parallel to this alar tragus line. Always use this. Fox occlusal plane indicator. Always use this. No, don't try otherwise. Always use this. And then see, it is parallel to the adjusted the maxillary occlusal plane, and mandible you have to do it separate. Mandible you have to do it separate. Natural teeth, how it looks, this is how it looks. You see, at rest, when the patient is at rest, the canines, the tip of the canine and the premolar will be slightly elevated from the remaining. It will be slightly above. This is in natural. When the patient is trussed and the mouth is slightly open, this is in natural. Don't try to duplicate this to the complete denture. It will have a horrifying look. For complete dentures, all the anterior teeth should be in the same level, maybe up to the first premolar, should be at the same level. See, this is the occlusal plane what you get. When you see, this is another important indication whether you have gone, whether you have done your, whether you have recorded the correct occlusal plane or not. See the measurement from the flange of the maxillary denture to the occlusal plane, and from the flange of the mandibular denture to the occlusal plane, the distance will be almost same. That means the total denture height will be equally divided for the maxilla and mandible by the occlusal plane. The maxillary denture height will be same as the mandibular denture, or almost the same, maybe 1 or 2 millimeters here and there. So the occlusal plane divides the maxillary and mandibular denture available space into equal halves. That you have to keep in mind. Never the maxillar denture will be too much long, or the mandibular denture will be too much long. Never it is going to happen. It will be almost equal. Okay, posterior occlusal plane, you know where to keep. It has to go up to the anterior third of the retromolar pad, anterior 2/3 of the retromolar pad. Okay, anteriorly at the level of the lower lip at rest. When the patient is at rest, we are keeping the occlusal plane will be just, you will see that the occlusal plane is just merging with the lower lip permeon border. So for maximum stability, this is what you should have. The denture should slightly come to the occlusal aspect of the teeth. See, it's slightly overlapping the occlusal aspect of the teeth. So all the movements will take place above the denture, and the lateral borders of the tongue try to seat the denture in place. See, for maximum stability of the mandibular denture is obtained, place the mandibular teeth slightly below the bulk of tongue. Majority of the tongue movements take place above the denture and tends to keep the denture down. It will seat the denture there. You need not arrange a separate chair for the mandibular denture. Usually when the patient comes for adjustment, the patient will come and sit and he will search for the next chair, where it is, for whom we are searching. I have to keep my denture. No, the mandibular denture will be seated by the tongue if you determine the occlusal plane correctly. That is why I told you occlusal plane also has a role in the denture looseness. See here, it is just pushing, it is just grabbing the mandibular denture to be seated. The tongue is pushing it down, the cheek is pushing it down. Where it will go, it will stay there. Provided you place the teeth in its proper position. That we will see. Provided you place the teeth in its proper position. That you have to remember. So this is since it has come regarding the occlusal plane region, I have just kept this. Actually, it has to go into the aesthetics. One thing what you have to mark in the maxillary in the occlusal rim is, so always you will be marking the midline and you will be marking the canine line. So this will give an indication of width of the combined anteriors, a rough indication of the combined all 6 anteriors together, how much it should be. One more thing you have to mark is regarding this, the high lip line. Ask the patient to give a broad smile and mark how much the upper lip has pulled up. Just put a mark. If you mark this, definitely you will know how much teeth will be visible. Definitely you will know how much teeth will be visible. So you can determine the length of the teeth also. So the length you got and the combined width you got. What more do you need for an anterior teeth? Like that is straight. Okay. The color. So imagine if the patient is showing this much visibility. If you are placing a teeth like this, a small teeth like this, what will happen when the patient smiles? The entire gingiva will come. The denture base will be shown. That pink thing, the aesthetics won't be good. But whereas if you place a teeth of this length, the patient will have a better smile. Okay, just say places and use a good articulator, at least minimum mean value articulator. Throw away that hinge articulator to minimize the occlusal discrepancy. Definitely, mean value will be better than the hinge. I'm not telling mean value is mean value is a very good articulator and it is going to replace all the things. Better replace the hinge with a mean value. You will get better results. The looseness can also occur because of the positioning of the as the positioning of the teeth is also not right. See, in this picture, you have an area over here. This is the tongue, this is the cheek, the alveolar ridges, the mucosa, all those things. A white space which is shown here is the potential denture space. Is the potential denture space. So here the flanges will come, here the teeth will come. If it is in that position, the denture will properly sit. If you are placing the teeth towards the tongue, you are encroaching the tongue space. Tongue is going to disturb your denture or unseat your denture. If you are placing it towards the buccal aspect, if you are encroaching the cheek space, cheek will push it out. So this space where the tongue force and the cheek force or the lip force is neutralized, or that force won't act, that particular area is called as a neutral zone. So always try to place the denture in the neutral zone, and always the outer surface of the denture, the polished surface, should have the glaze, so that the cheek will get stuck to that region. See the contour. Actually, the maxillary and mandibular dentures are converging to the occlusal aspect. It is converging to the occlusal aspect. So the cheeks and the tongue will adapt to its borders. See how it is. So the tongue and the cheek will seat the denture. This is what I told you. If you are placing the teeth in, if you're each and every step, if you are doing it carefully, the extensions, the placement of the teeth, all this adds to the retention. You need not go for any other management. Just do it properly. Just do it according to the space available from the patient, or according to the space provided by the patient. You fabricate the denture to be in harmony with the oral cavity. Never try to harmonize our denture to someone's oral cavity. The denture what we make, don't try to push it in. The denture what the mouth needs, you give. That is what you have to. So the cheeks and the lips, the tongue will seat the denture. See the placement of anteriors in a very it has got a limit. You see, this is the sulcus width what we have. The labial aspect can come a maximum up to half of the sulcus width, the labial aspect, so that it will provide adequate width. Here you have a well-formed ridge. Here you have a resorbed ridge. Actually, it is kept away from the ridge, but it is in the neutral zone. This is the sagittal section what shows the potential denture space. This is the tongue. This is the lower ridge. This is the lower lip, upper arch. So this is the potential space. How the lips get and the tongue comes and sits. See the anterior tongue at rest it will come and stay here. It is going to seat the denture. So if you try to support the lips more with the teeth, definitely it will unseat. More label placement causes tilting of the mandibular denture. So it has to be in the space allocated to them by the nature. Again, buccal placement of the teeth is decided by the modulus. I told you modulus will be coming later. Modulus is you know where it is present at the ankle of the mouth. Actually, several muscles come and meet at this modulus, and modulus is the portion which gives the seal at the angle of the mouth. It creates the seal when you close the mouth tight. Okay, it will tie at both the corners. Your mouth will be what you get the seal over there. Okay. So mold the occlusal rim, clean the occlusal rim, and ask the patient to swallow or ask the patient to close the lips tight. Definitely, the modulus will mold those regions. Usually, our rims we may not extend up to it. If you are extending, you have to see whether during contraction the dentures or the denture base is unseating. Anyway, your denture borders has to be little adjusted like this. The polished surface has to be like this at the modulus region. So to avoid the placement of teeth towards buccal or lingual aspect, the regular thing what you have to do is after arranging the anteriors, mandibular anteriors, to mark the retromolar pad, and you draw a line from the tip of the canine to the retromolar pad. And while doing the teeth arrangement, make sure that the central grooves will run through this line. So definitely you are going to place the teeth on the ridge. Never it goes to the buccal or to the lingual. Never it goes to the buccal or to the lingual. So this you can use as a guide for doing your teeth arrangement. So if it is going to the buccal, you know what happens, the cheek will push. If it is going to the lingual, you know the tongue will act. So you should know where the teeth should sit. You should know where you should sit. That also is very important. Next, regarding looseness, we have seen. Next, we are going to the pain. Pain, that is discrete painful areas. Discrete painful areas. The painful areas usually soon after fabrication of the denture. First thing what we have to do is you have to feel the fitting surface of the denture. Just pass your fingers onto the fitting surface of the denture. Feel for any sharp ridges, any nodules. Okay, if you feel that, just trim it off. Just trim it off. Sometimes you need the use of a disclosing agent. Apply it, keep it in the patient's mouth. Where there is excess contact, the disclosing agent will be displaced. Take it out and trim it off. Another area where pain usually comes is regarding the undercut region present on the ridge. This is going to create pain while insertion and removal. Once it passes this maximum height of contour, then the pain won't be there. But whenever the patient seats or whenever the patient removes the denture, this region is going to be painful. So you have to relieve the denture. Don't try to cut this off. You have to relieve that fitting surface of the denture. Here also you can apply a disclosing agent. Where the disclosing agent is getting displaced, you trim off. Okay. Another great things what people do. Tremendous pain will be there. What this tooth is going to help. It is better you extract it and do. But sometimes people insist on having their own teeth. We will tell him, see, all the 32 you had, the remaining 30 is gone. Then why you want these two? No, this is my natural teeth. Okay, now we have to yield because we only have educated them for preserving the natural teeth. Okay, agreed. But definitely it is going to create headaches for you. You inform them it is going to create headache. Make a denture, Occlusal type you can give. But what about this undercut? You have to relieve the fitting surface. The dentures naturally it will become groove. it will become loose. The pain will be relieved, but it will become loose. Then you have to reline with a soft liner. But just like this, after extraction, no compression was done, severe undercut. Pre-prosthetic surgery is the option, but patient alveoloplasty has to be done. But the patient, many patients won't be ready. Trabeculated denture, relieve from the inner surface, give a soft liner. Another thing, two giant eyes looking at us, retained roots. Definitely, this is going to arrest the resorption. Then what about all this resorption? Who will take care? But still, the patient insists, okay, to give some support also. Okay, fabricate. But what about the pain caused over here? Relieve it nicely. The fitting surface. You may have to give a soft line if it is becoming loose. Soft liners, it may stay up to 3 or 4 months, maybe up to 6 months, not more than that. Afterwards, you have to redo it. So all these undercut areas created, or all the undercut area present, if surgical correction is not possible, or if the surgical correction, if the patient is not ready to go for surgical correction, never hesitate to do a denture. Do the denture, relieve the undercuts, relieve the denture fitting surface, and if the denture is becoming loose, reline it with a soft line. Overextension, again, use a disclosing agent. Wherever it is getting displaced, you can. But some areas, especially the distolingual flange, some areas you may leave it as such because the elasticity of the muscles may permit. Just once you can try, second time again, if the patient complains, definitely apply the disclosing agent once identify the region and trim it off. Okay. So this is the disclosing agent what we can easily use. The zinc oxide paste of the zinc oxide digital impression material. Applied with a denture brush or a toothbrush onto the surface. These strokes should be there. Then only you feel that, then only you will identify, because the strokes, wherever it is not continuous, there you can relieve. Okay, apply it with your toothbrush. Seat it in the patient's mouth. Ask the patient to bite on a cotton roll. Wherever it is being displaced, you can remove it with a burr. As far as possible, use tungsten carbide burrs for trimming. It is very efficient. Tungsten bar, good quality tungsten carbide bar. Tungsten carbide burrs are available from 80 rupees to 700 rupees. Good quality. Usually it is color coded. The black, blue, green, red, yellow, white. Like that it goes. Okay, black is for gross trimming. Then green is for the next finer one. Then comes blue, red, yellow, and white is smooth. Yellow is the super fine. White very rarely I have seen. Anyway, tungsten carbide burrs can be used for finishing and polishing. Generalized pain over the denture supporting area is mainly because of the loose denture or underextended denture base and inadequate freeway space. That means vertical dimension has increased. If it is under extension, you can do the border molding once more, and you can modify it. If it is decreased freeway space, if it is very less, you can do some occlusal adjustments and correct it. If it is severe, it is better to change the entire denture, or at least the teeth. Jaw relation has to be repeated and done. The denture base, you can use it. Another region where there is severe pain is this condition. The mandibular ridge severely resolved. The neurovascular bundle has come up. It is almost touching the coast. Very sharp mandibular ridges. All this cause generalized pain. Then the presence of any pathology within the alveolar bone can also cause generalized pain. Regarding aesthetics, mainly depends upon the anterior teeth size and shape. I told you regarding determining the occlusal plane. Here you can see even with a small smile, the patient is showing the entire teeth. That means her smile line has not been, your high lip line has not been recorded. So visibility is more. And see how the midline is. Midline is shifted towards the left, patient's left. Okay, failed in determining the midline as well as failed in the visibility. How to visibility? I have told you already. What about the midline? Take the facial midline we see. So we keep on seeing from here. Come down, come down, come down. Okay, the tip of the nose is turned towards one side. What will you do? Will you take it this side? Or if it is turned towards this side, will you take it this side? Okay, again, okay, we'll come to the center, 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 center. Ultimately, when you reach, you will land up here. So don't start from here. Start from here. Just down to this, you have the lobule. There will be the midline. Facial midline. Don't compare it with the nose tip. Don't start from the top. Start from the nearer structure. That is 99% of the cases. See this. Thus, the midline can be. The size and shape, I told you regarding the marking of those lines, canine lines, as well as the high lip line. A rough idea of size and the height and width of the teeth can be positioned. Then visibility, all these things has to be correct. Facial aesthetics, how the lips are supported, how the wrinkles disappears, how the philtrum looks, how the columella philtrum angle looks. See here, this is the columella philtrum angle, obtuse, it is more acute. See here, this is an edentulous condition where the patient has not worn the denture. See the upper lip, it has turned in, but here, when the lip has got adequate support, it has come out. Okay, that itself creates a lot of difference. Visibility of the vermilion is another important one. The wet and dry zone will be more placed towards outside. Here it has gone in. Then nose chin approximation, vertical dimension has to be correct. The angular cheilitis, vertical dimension causes that loss of vertical dimension or decrease in vertical dimension. Next is regarding the gagging. Or extended dentures, as I told you before, you don't know where to limit. Or extended dentures can cause gagging. Unstable dentures because of improper peripheral molding. Underextended dentures. Then posterior borders made very thick posterior borders. When the patient starts swallowing, the patient will tell you, I feel something at the throat. Something is touching, the denture is touching at the throat. That is just because this thickness is felt by the tongue. So always trim the borders, always trim the posterior aspect towards the tissue. Make it thin towards the tissue, never the reverse. You don't make it thin from the tissue towards the denture. Make it from the denture towards the tissue. A slope from the denture towards the tissue. Okay, then insufficient tongue space, too much thickness of the denture. Insufficient tongue space, that also causes gastroenteritis, psychological factors, alcoholism. 90% of people say he is gagging, it is psychological. No, you have to check all these things, then only you can say it is psychological. First, the local thing has to be addressed, then go for all those things. Swallowing difficulty, if the thickness is more, the denture thickness is more, people will have swallowing difficulty. If the dentures are poorly fitting, again, swallowing difficulty will be there. Studies have shown that poorly fitting denture around 1.8 per seconds, and for newly fitting denture, poorly fitting around 1 point, and new properly fitting denture around 1.2 seconds needed for swallowing. So how that swallowing is also affected by our improper technique. Implant supported our denture, a good option. Presently, what people say is restoring the edentulous mandible with a conventional complete denture is not an first treatment of choice for a edentulous mandible. That is what we say. Treating or restoring the edentulous mandible with a conventional denture is not an ideal treatment. That is what presently we say. At least the denture has to be retained with the 2 implants. And that is the treatment of choice. Okay, if the dentures stay in place, it's well and good. If it is stay in place, it is well and good. You need not worry too much regarding the bottom molding. You need not worry too much regarding the many factors what we have discussed. But later on, it was found that when studies were conducted, it was found that anterior mandibular bone resorption decreased from 0.4 millimeter annually to 0.1 millimeter. There was definitely a decrease in the in bone resorption in the anterior aspect of the mandible. Annually, if it was of 0.4 millimeter, after insertion of the implant, it was just 1 millimeter. Ah, what a wonderful thing. The bone is being preserved. The bone is staying there. What more you need in an edentulous mandible? So from 0.4 millimeter, it has come to 0.1 millimeter. That means 0.3 millimeter we have saved with 2 implants. Ah, very good. But what happens in the posterior region? What happens in the posterior region? The resorption rate was 2 to 3 times higher in patients with overdentures, implant supported overdentures. That was the condition. Anteriorly, definitely it checked the resorption, but posteriorly it increased the resorption. That too, 2 to 3 times. Okay, so what finally they concluded is for younger edentulous patient, that means if the patient is around 50 or 60 and if he is becoming edentulous, 50s are now considered as young. Okay, not because I have reached 50. No, now 50s are considered as young. Okay, I know Adina won't agree, but still 50s are considered as young. Okay, so young patient with an overdenture with 2 implants is questionable nowadays. If you want to give an overdenture, you place more implants. Definitely, if you can place more implants, you can give a fixed option. So that is questionable. These 2 implant supported overdentures may be given for a older age group, maybe 60, 70, 70, 80 like that. It is acceptable. Speech difficulties, mainly because of the thick posterior border, and this posterior border will irritate the dorsum of the tongue, and it can also unseat the denture. All these things will affect the speech. Speech can be affected also by improper anterior posterior positioning of the anteriors, especially the incisors. This particular thing we do it for checking the jaw relations also, vertical relation. Vertical relation, you remember, you do the physiologic transposition method. We call it as the Niswanga's physiologic transposition method. You determine the vertical relation and then you use this. Yes, that is suggested by Silverman. We call it as Silverman's closest speaking space. So if the vertical dimension has been correctly recorded, when the patient says yes, the mandibular occlusal rim will come slightly forward and it will be just in level with the maxillary occlusal plane, not touching that. There will be a small amount of gap and the patient can pronounce yes correctly. If the vertical dimension what we have determined is not correct, the mandible will come and hit and yes won't come. So this sound depends on what the correct recording of the vertical dimension. Okay, the upper and lower incisor move close. The air stream is allowed to escape to the slight opening between the teeth. Again, yes, like that, yes will come. Okay. See, if this space is not there, yes will be softened. It will come as. If it is deep, it will be whistling. Imagine an 80-year-old patient wearing a denture and start whistling. Can he go around in the public? Then sounds like C, D, T, N, S, Z, and R. The contact of tip of the tongue occur at the anterior part. That means almost at the anterior part of the palate. So if the denture thickness is more at the anterior aspect, especially at the ruger region, if the denture thickness is more, it sounds different. Mainly because once the thickness is more, the air volume which is present over there will be decreased, and the space available for the tongue will also be decreased. So the thickness also causes damage. Thickness is needed for a certain thing for strength, but beyond that, it is dangerous. Say another thing, the labiodental sounds. This also we use for knowing the proper labiopalatal placement of the anteriors, F and V. When you pronounce F or V, what happens is the lower lip slightly rises and contact the incisal edges. So the incisal edges will be contacting the wet and dry zone of the lower lip or the vermilion of the lower lip, whatever it is, F, V, F, V. So the incisal edges should touch there. Then only you can pronounce F, V, F, V. Just try F, V. The incisal edges should touch there. So that is a guide for the placement of the maxillary anteriors. If you are not placing the maxillary anteriors properly, again, this sound will be affected. What happens? Here, again, we are going back to occlusal pain. Occlusal pain is too high. That means the mandibular occlusal plane, you have brought it too high towards the maxilla. The correct positioning of the lower lip may be difficult. At rest also, you can see half of the mandibular incisors in the patient's mouth. The patient cannot talk properly. The occlusal plane has been changed. If the occlusal plane is kept too low, the maxillary denture will be too long. Then the lower lip will overlap the labial surfaces of the anterior teeth. Again, the speech will be affected. Those sounds he cannot produce. Another other complaints, inefficiency, means mainly inability to eat. Then vertical dimension, excess or insufficient. We know how to check for the vertical dimension. I told you a few minutes back. Vertical dimension we determine by physiologic transposition method, and we confirm it by Silverman's cross speaking space by telling S. When you tell S, the incisors will come forward, just leaving a space, 1 millimeter space between the upper and lower. So if you have recorded the vertical dimension in transposition method correctly, you just verify by asking the patient to say S. Mississippi 66. That is why we ask the patient to say Mississippi 66, all those sounds. It is not that we are checking the patient's IQ. We are just referring. And even after determining the vertical dimension, you just talk to the patient, ask him something. The patient will if he is talking very comfortably, you can ensure that the vertical dimension is correct. If it is not correct, patient will find difficulty in pronouncing many words. That is especially true if it is excess. If the vertical dimension is less, you won't know. Nothing will happen. Everything will function properly. You won't know. Later on, you will know. Okay. Then the incorrect registration of the centric. Usually we record the retruded contact point in for complete dentures. Okay, you ask the patient to retrude and bite, or roll the tongue back and bite, or you can guide for registering the centric relation. How it has been done, I think all this needs a separate session to be discussed. Anyway, that also can cause denture failures, bone of teeth, all those things cause fracture of the cusp. Then inexperience. Patient should be ready to accept the change. That is why I told you, you have to motivate the patient constantly. Uncommon complaints, whistling. I told you the S space, the deficiency, what it comes, whistling. Then the earache. Earache usually occurs after a certain period, mainly because of the decreased vertical dimension. Difficulty in swallowing, mainly because of the denture extension. Food and saliva accumulating beneath the denture, that is mainly because of the maxillary, mainly because of the posterior palatal seal not being recorded properly. Even for the mandibular denture, if it is not placed, the tooth not placed on the neutral zone, or if it is not the mandibular denture is not balanced by the cheeks, and the lip, that means functional molding has not taken place. All those things can cause this. Frenums not relieved properly. Placement of the teeth too buccally or lingually. Loss of taste, that definitely it will be there. You have to caution the patient regarding this, because the minor salivary glands which is present on the palate is completely covered by the maxillary denture, and usually we feel the taste by touching the tongue on the palate. That touching feel also adds to taste. That is entirely lost because you're covering the palate with your denture, so that is entirely lost. Next is the sore throat, that mainly because of the distolingual extension of the mandibular denture, and you may encroach the retromylohyoid curtain. That also can cause a little bit sore throat, sneezing, coughing, all those things. Allergy. I've come across an allergic patient to denture. We managed it by usually pigments added to the denture in fabrication of things added to the acrylic cause this allergy. We managed that patient by giving a clear denture to him. He used a clear acrylic, so heat clear acrylic. Like that you can manage it. A dry mouth. See for what all medication he is taking. Accordingly, you can advise him. Actually, saliva is absolutely necessary for retaining the denture. Okay, the cheapest way to keep the mouth wet is by asking the patient to sip water. Another uncommon complaints, clicking of teeth. You know what happens? Increase in vertical dimension. Or nowadays nobody is using porcelain teeth, so mainly increase in vertical dimension or improper occlusal plane. Then restriction of the tongue. By this time you know how the tongue space gets restricted by improper placement of the teeth, or by increasing the thickness. Angular chilates again decreased vertical dimension. Then the cheek bite, lip, tongue bite, improper position of the halitosis, poor maintenance, drooling of saliva, again loss of vertical dimension. All these complaints can occur. So when we're almost reaching to the end, when a patient reports to you, those who are sleeping can wake up. When a patient reports to you with a lot of complaints, you just go through a checklist like this. Whether you have given adequate previous space, the centriculation correct, registered correctly, the lip supported well, whether the occlusal plane is in harmony. See the importance of occlusal plane in denture retention. Occlusal plane is in harmony. Are the dentures retentive because the peripheral molding has been done and the flanges are properly checked? That is the pain on biting, any para function, whether night grinding, something like that. You do all those, check all those things. The important thing what you have to do is patient education. Tell him the limitations of using the denture. Okay, most of the patient come to us telling that he can't eat meat. He wants to eat meat. He wants to eat biryani. He wants to break the bone, the chicken bone or the mutton bone, whatever he is having. All those things we do. Tell him. See, once you are going to have a denture, you are going to have an artificial replacement done by a human being like me. It has limitations. It is not going to replace the God-given structures. Never. Humans are humans and God is God. What God is given, you didn't take care. Then how can I help you? I can help you up to a certain limit. That limitation you have to explain. Our dentures are never going to be an absolute replacement for the natural teeth. The limitation has to be told to the patient, and don't educate them more, because the patient will run to the second clinic. There he won't educate and he will give a denture very comfortably. The patient will wear. Don't educate him too much. You educate him. Forewarning. In advance, you tell him regarding the looseness of the mandibular denture. You tell him it is not. We will do the procedures correctly, and you will do the procedures correctly. You will use the proper material. You will use the proper material, and you will put all the efforts. And the remaining thing is with you. You tell the patient. You have to achieve the balance of the denture with your cheek, your lip, and your tongue. That you have to tell. You compare the amount of space available between the maxilla and mandible. patient will become aware. Tell him. So definitely, if you do a proper work, the mandibular dentures will see. It never it is going to be as retentive as a maxilla, but if you place the denture tooth position properly, if you do the peripheral tracing properly, if you correct if you give the correct shape for the flanges properly, it will see. So explain him everything, educate him. Definitely the dentures are going to see. This is what I got from my friend, Dr. Gaigi Matthew. Today morning, he has posted this picture in WhatsApp. Okay, when it is denture patient's 10th visit. Hope it is not Gaigi who's sitting beside. Thank you. I would like to thank my guru, Dr. Chandrasekharan Nair, is always a leading light for me. I think now also he teaches me the things and I am ready to accept whatever advice he's given. Thank you, sir. This is my team, my staff members, Dr. Shahin, Dr. Nikhil, Dr. Chandrathara, Dr. Dhanya, Dr. Gauri, and Dr. Arya, and these are my PG students. These are my references. Thank you. Okay, wake up.
Thank you. Thank you, Professor Pradeep Dathan, for the well-explained and the lecture, which is enlightening for all of us. ഇനി തൊട്ടെങ്കിലും നമ്മുടെ എല്ലാം ഫിക്സോൺ എന്ന പൗഡർ നമ്മുടെ ക്ലിനിക്കിൽ നിന്ന് മാറ്റി വയ്ക്കാൻ പറ്റുമെന്ന് ഞാൻ ആത്മാർത്ഥമായിട്ട് വിചാരിക്കുന്നു. I invite Professor Dr. Sudeep Sharachandran to have an acknowledgement of the lecture. Dr. Sudeep is here.
Pradeep. Yeah, I'm here.
Oh.
Pradeep,
Namaskaram.
Namaskaram. Really, actually, it was an extensive, post-insertion complications in the പറയുമ്പോൾ എല്ലാവരും വിചാരിക്കും ആ ഒരു ടോപ്പിക്ക് മാത്രമാണ്. But it's not like that. Post-insertion complications വരണ്ടെങ്കിൽ from the case history selection, case history എടുത്ത case selection തൊട്ട് fabrication വരെ perfect ആണെങ്കിൽ മാത്രമേ that the post-insertion complications will be less. That everyone should understand. That's അതുകൊണ്ടാണ് പ്രദീപ് സാർ ആദ്യം തൊട്ട് തന്നെ actually he was taking all he was going through all the points basically for ആദ്യത്തിനുള്ള procedures തൊട്ടുള്ള points പലതും actually he was explaining in detail, and actually it is a very vast topic. Basically it's a very vast topic, and Dr. Pradeep has done it very എന്താ പറയുക എല്ലാവർക്കും മനസ്സിലാവുന്ന രീതിയിൽ നല്ല രീതിയിൽ he presented it. Really congratulations Dr. Pradeep. Congratulations, I have done a good and actually either your topic basically it's needed for everyone, those who are doing complete dentures. Complete denture matramalla, this is applicable to all the other procedures also. Dentures nu parayumba complete denture matramalla nammal pala dentures kodukkum, and it's applicable to all dentures. Appo adonde Pradeepinte ee oru talk actually basically it has given a inside knowledge of what all the private practitioners should do when you start doing a denture procedure or a prosthesis procedure. Anyway, congratulations, Dr. Pradeep. You have done a good job.
Thank you.
And thank you for your enlightening talk. Thank you.
Thank you, Dr. Sudeep. I invite our state IPP, Dr. Abhilash GS, to have a few words.
ഇത് ഡൗട്ട്സ് ഒന്നും ഇല്ലേ ആർക്കും?
Yeah, after this we are going to the no, we are not concluding. After this we are going to the questionnaire session.
Okay. Thank you, Dr. Pradeep. Anyway, പ്രസിഡന്റ് വിളിച്ചതിലേക്ക് ഞാൻ രണ്ട് വാക്ക് പറയാം. പ്രദീപ് സാറിനെ കുറിച്ച് പറയുകയാണെങ്കിൽ അദ്ദേഹത്തിന് ഈ പറഞ്ഞ ഒരു വളരെ എമിനന്റ് ടീച്ചറാണ്, വളരെ സ്റ്റുഡന്റ് ഫ്രണ്ട്ലി ആണ്. എനിക്ക് വളരെ തുടക്കം മുതൽ അറിയാം. ബിക്കോസ് അദ്ദേഹത്തിൻ്റെ കൂടെ കോളേജിൽ തന്നെ ഇടയ്ക്ക് ഇൻസ്പെക്ഷനൊക്കെ പോയിട്ടുള്ള എക്സ്പീരിയൻസും ഉണ്ട്. പിന്നെ അദ്ദേഹം ഒരുപാട് പോസ്റ്റ് ചെയ്തെന്ന് പറഞ്ഞെങ്കിലും ഏറ്റവും ഇമ്പോർട്ടൻ്റ് ആണ് നമ്മുടെ ഒരു പാസ്റ്റ് പ്രസിഡന്റ് ആണ് അദ്ദേഹം ഐഡിയ ആറ്റിങ്ങലിന്റെ. അതൊരു ഇമ്പോർട്ടൻറ്റ് പോസ്റ്റ് ഇരുന്ന ഒരു ഡോക്ടറാണ്. പിന്നെ ഐഡിയയിലും അല്ലാതെ ഒരുപാട് അവാർഡ്സ് കിട്ടിയിട്ടുള്ള ഡോക്ടറാണ്. മാത്രമല്ല ഹി വൺ ദ national award also for our journal impressions. അത് പിന്നെ അദ്ദേഹത്തിനോട് കൂടെ അക്കമ്പനി ചെയ്യാൻ എനിക്കൊരു ഭാഗ്യം ഉണ്ടായിട്ടുണ്ട്. അത് മേടിക്കാനായിട്ട് ഓൾ ദ വേ ടു ഭുവനേശ്വർ, ഒറീസ, അവിടെയാണ് നമ്മൾ അത് മേടിക്കാൻ പോയത്. എന്നത് സാറിന്റെ കൂടെ ഞാനാണ് പോയത്. അത് സന്തോഷമുണ്ട്.
യാത്രയുള്ള ഭാഗ്യം. മതി മതി.
പിന്നെ എന്താ പറയാ, വളരെ നല്ലൊരു ക്ലാസ് ആയിരുന്നു. ബിക്കോസ് ഇപ്പൊ അവരുടെ പ്രസിഡന്റ് പറഞ്ഞ പോലെ ഇതൊരു നൈറ്റ്മെയർ ആണ് ഈ ഡെഞ്ചർ. പല GP ജനറൽ പ്രാക്ടീഷേഴ്സിന് പലരും ഇതിന്റെ പോസ്റ്റ് ഇൻസർഷൻ കോംപ്ലിക്കേഷൻസോ അല്ലെങ്കിൽ പേഷ്യൻസ് എന്ന് പറയുന്ന കംപ്ലൈൻസ് കേൾക്കാൻ വയ്യാഞ്ഞിട്ടോ ചെയ്യാത്ത ഒത്തിരി ഡോക്ടേഴ്സ് ഉണ്ട്. പിന്നെ റിജ് എന്തെങ്കിലും ചെറിയ കുറച്ച് ഇതായിട്ട് തോന്നുകയാണെങ്കിൽ പോലും നിങ്ങൾ ചെയ്യേണ്ടെന്ന് പറഞ്ഞ ഒത്തിരി ജനറൽ പ്രാക്ടീഷേഴ്സ് ഉണ്ട്. അപ്പൊ അവർക്കൊക്കെ വളരെ യൂസ്ഫുൾ ആയിട്ടുള്ള ഒരു ലെക്ചർ ആയിരുന്നു ഇത്, ഒരു ക്ലാസ് ആയിരുന്നു. ഈ ടോപ്പിക് സെലക്ട് ചെയ്ത നമ്മുടെ ബ്രാഞ്ചിന്റെ CD വിങ്ങിനും അതുപോലെ ഒഫീഷ്യൽസിനും എൻ്റെ കൺഗ്രാജുലേഷൻസ്. കാരണം അത് വളരെ ഇമ്പോർട്ടൻ്റ് ആയിട്ടുള്ള വളരെ പ്രധാനപ്പെട്ട റെലവൻറ്റ് ടോപ്പിക്കാണ്. ഇങ്ങനെയുള്ള യൂസ്ഫുൾ ടോപ്പിക്സ് ആണ് നമ്മൾ ശരിക്കും സെലക്ട് ചെയ്ത് നമ്മുടെ GP ജനറൽ പ്രാക്ടീഷേഴ്സിന് കൊടുക്കേണ്ടത്. വെൽ ഡൺ CD വിങ് ആൻഡ് പ്രസിഡന്റ്, സെക്രട്ടറി ആൻഡ് അതർ എക്സിക്യൂട്ടീവ് മെമ്പേഴ്സ് ഓഫ് ID ആറ്റിങ്ങൽ. പിന്നെ ഈ ചെറിയൊരു തമാശയെ കുറിച്ച് നിർത്താം. അതായത് നമ്മൾ പേഷ്യന്റിനെ ഇത് കൺവിൻസ് ചെയ്യുമ്പോൾ ഉള്ള ചില പ്രശ്നങ്ങളാണ്. നമ്മൾ കുറേയൊക്കെ പറയും അതെങ്ങനെയാണ്. ഇപ്പൊ പ്രദീപ് സാറും പറഞ്ഞു ഇത് ഗോഡ് ക്രിയേഷൻ ആണ്, അതുപോലെ നമ്മൾ വെച്ചാൽ എന്തായാലും വരില്ല എന്ന് പറഞ്ഞിരുന്നു. നമ്മുടെ ഇൻസ്റ്റലേഷന് പണ്ട് ടെക്നോ പാർക്കില് ഡോക്ടർ പ്രേംകുമാർ വന്നിരുന്നു. കൊടുങ്ങല്ലൂർ ഒരു സീനിയർ ഡെന്റിസ്റ്റ് ആണ്, ഒരു ഭയങ്കര പ്രാക്ടീസ് ഉള്ള റോറിംഗ് പ്രാക്ടീഷണറാണ്. അദ്ദേഹം പറഞ്ഞൊരു കാര്യമുണ്ട്, ഇതൊരു നൈറ്റ്മെയർ തന്നെയാണ്. കാരണം ഡെഞ്ചർ വെച്ചു കൊടുത്ത് പുള്ളിയുടെ എക്സ്പീരിയൻസ് ആണ്. ഒരു അമ്മച്ചി വന്നു, പുള്ളിക്കാരി എന്നും രാവിലെ ക്ലിനിക്ക് വന്നിരിക്കും, ഇരിക്കുന്നില്ല, ഇത് ചാടിപ്പോകുന്നു, എന്ത് പറഞ്ഞാലും എത്ര ചെയ്തിട്ടും അത് ശരിയാകുന്നുമില്ല, എത്ര കൺവിൻസ് ചെയ്യാനും പറ്റുന്നില്ല. അവസാനം ഡോക്ടർ പറഞ്ഞു, അമ്മച്ചി പ്രദീപ് ഡോക്ടർ പറഞ്ഞ പോലെ തന്നെ, അമ്മേ ഇത് ദൈവം തന്ന പല്ലുപോലെ ആവില്ലല്ലോ, ഞാൻ എത്ര വെച്ചാലും ഞാൻ ദൈവം അല്ലല്ലോ, അതുകൊണ്ട് അമ്മ ഒന്ന് അഡ്ജസ്റ്റ് ചെയ്യണം എന്ന് പറഞ്ഞപ്പോൾ പറഞ്ഞു, മക്കൾ പറഞ്ഞത് വളരെ 100% ശരിയാണ്. ദൈവം തന്ന പല്ലുപോലെ ഡോക്ടർ വെച്ച പല്ല് ആവില്ലാത്ത എനിക്കറിയാം. പക്ഷെ അന്ന് ദൈവത്തിന് ഞാൻ പൈസയൊന്നും കൊടുത്തില്ലായിരുന്നു, ഡോക്ടർ നല്ലൊരു എമൗണ്ട് എന്നെ ഒന്ന് വാങ്ങിയത്. ഇതായിരുന്നു അവർ പറഞ്ഞ മറുപടി. സോ നമ്മുടെ ഒരു ഇൻസ്റ്റലേഷനിൽ പ്രേംകുമാർ സാർ പറഞ്ഞൊരു കമന്റാണ്, കറക്റ്റ് ആണ്, സംഭവ ദൈവമാണ്. അപ്പൊ അങ്ങനെയുള്ള പേഷ്യൻസും ഉണ്ട്, നല്ലപോലെ തിരിച്ച് കൗണ്ടർ ചെയ്യുന്ന ആൾക്കാരും ഉണ്ട്. അവരെയൊക്കെ കൺവിൻസ് ചെയ്തെടുക്കുക എന്നുള്ളത് ഒരു എന്താ പറയാ, ഒരു ഹെർക്കൂലിയൻ ടാസ്ക് ആണ്. എനിവേ കുറെയൊക്കെ എത്രത്തോളം നമുക്കത് എന്താ
പറയണം, പൈസ വാങ്ങിച്ചിട്ടില്ല, പൈസ വാങ്ങിച്ചിട്ട്
അതുകൊണ്ട് എന്തായാലും ഇതൊരു വളരെ യൂസ്ഫുൾ ടോപ്പിക് ആയിരുന്നു. ഈ പറഞ്ഞ കാര്യങ്ങളൊക്കെ വളരെ നല്ല ലെക്ചർ ആയിരുന്നു. താങ്ക് യു ഫോർ ദ പ്രസന്റേഷൻ, താങ്ക് യു ഫോർ ദ സെഷൻ, താങ്ക് യു പാർട്ടിസിപ്പൻസ് ഫോർ ഒരു നല്ല പാർട്ടിസിപ്പേഷൻ ഉണ്ടായിരുന്നു. താങ്ക് യു ആൾ.
Thank you, Dr. Abhilash. Participants, kindly be ready with your questions. I invite Dr. Bijoy Nair, our Chartered Secretary and member of State Dental Council. Dr. Biju, please, if you are there.
Thank you, President. Actually, it was a very wonderful and informative session. So, ഞാൻ വിചാരിച്ചിരുന്നത്, ഇനി മലയാളത്തിൽ തന്നെ പറയാം, ഞാൻ എല്ലാവരും മലയാളത്തിലല്ലേ പറഞ്ഞു, ഞാൻ വിചാരിച്ചിരുന്നത് ഡെഞ്ചർ, പോസ്റ്റ് ഡെഞ്ചർ ഇൻസേഷൻ വരുമ്പോഴത്തേക്ക് ആ ഡെഞ്ചറുമായിട്ട് വരുമ്പോൾ അത് എങ്ങനെ ഗ്രൈൻഡ് ചെയ്യണം, അവിടെ ഗ്രൈൻഡ് ചെയ്യണം, അങ്ങനെയൊക്കെ ഒരു രീതിയിലുള്ളതാണ് പ്രതീക്ഷിച്ചിരുന്നത്. പക്ഷേ ആക്ച്വലി എനിക്കിത് കേട്ടപ്പോൾ മനസ്സിലായത് പോസ്റ്റ് ഇൻസേഷൻ കോംപ്ലിക്കേഷൻ ഉണ്ടാകുന്നത് ഡെഞ്ചർ ഉണ്ടാക്കുന്നത് പോസ്റ്റ് ഇൻസേഷൻ കോംപ്ലിക്കേഷൻ ഡെഞ്ചർ ഉണ്ടാകുന്നത് ശരിയാകത്തോണ്ടാണ് കോംപ്ലിക്കേഷൻ വരുന്നതെന്നാണ് നമ്മുടെ ഡോക്ടർ പ്രദീപ് പറഞ്ഞത്.
നമ്മളെപ്പോഴും ഫിക്സ് ഓൺ മേടിച്ച് ക്ലിനിക്ക് വെച്ചേക്കുന്നത്
ഞാൻ അഞ്ചെണ്ണം ഒരു സമയത്ത് എപ്പോഴും. അപ്പോ ശരിക്കും അതിന്റെ റീസൺസ്, ഇപ്പോ പ്രാക്ടീസ് തുടങ്ങി 25 വർഷമായെങ്കിലും അറിഞ്ഞുകൂടാതിരുന്ന പല 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 കാര്യങ്ങളും മനസ്സിലാക്കാൻ സാധിച്ചു. ഈവൻ ഡാർക്ക് ഏരിയാസ്, മനസ്സിലാകാത്ത കാര്യങ്ങൾ ഇപ്പോഴും അദ്ദേഹം പറഞ്ഞു, അതിനെ ചോദിച്ച് മനസ്സിലാക്കണം. പിന്നെ ഡോക്ടർ പ്രദീപിനോടൊപ്പം ഞാൻ ഭുവനേശ്വറിലൊന്നും പോയില്ലെങ്കിലും അദ്ദേഹത്തിനെ ഞാൻ ആദ്യം പരിചയപ്പെടുന്നത് 97-ലെ അദ്ദേഹം അന്ന് BDC കഴിഞ്ഞ സമയമാണ്. BDC കഴിഞ്ഞിട്ട് അദ്ദേഹം ആദ്യം ഒരു ക്ലിനിക്ക് തുടങ്ങിയത് ആറ്റിങ്ങൽ. അദ്ദേഹത്തിന് തന്നെ അത് ഓർമ്മയുണ്ടോന്ന് എനിക്കറിയില്ല. പ്രദീപ് ആദ്യമായി ക്ലിനിക്ക് തുടങ്ങിയത് ആറ്റിങ്ങിലാണ്, മാർക്കറ്റ് റോഡിൽ. പുള്ളി അത് മറന്നു.
അതെ അതെ. നല്ല ഓർമ്മയുണ്ട്.
വൈകുന്നേരങ്ങളിൽ ആറ്റിങ്ങിൽ വെച്ച് കാണുമായിരുന്നു. പിന്നീട് ആറ്റിങ്ങിൽ ബ്രാഞ്ച് തുടങ്ങിയപ്പോൾ നമ്മുടെ ഫൗണ്ടർ മെമ്പറായിട്ട് വന്നു, ഓഫീസറായി, പ്രസിഡന്റ് ആയിരുന്ന സമയത്തും ഞാൻ ഓർക്കുന്ന കാര്യങ്ങൾ പറയാം. എക്സിക്യൂട്ടീവ് മീറ്റിംഗ് നടത്തുമ്പോൾ അദ്ദേഹം പ്രസിഡന്റ്, ഞാൻ അവിടെ തന്നെ ഉണ്ട്. എന്ത് പോസ്റ്റിനെ ഓർക്കുന്നില്ല. പെട്ടെന്ന് ആറ്റിങ്ങൽ ഹോട്ടൽ ഗംഗയിൽ വെച്ചാണ് മീറ്റിംഗ്. ഭയങ്കരമായ ബഹളം, എല്ലാവരും കൂടി ഭയങ്കര ഒരു വോയിസ് ആയപ്പോഴത്തേക്ക് പ്രസിഡന്റ് ഒരു ഒറ്റ അടിയൻ പെട്ടെന്ന് ഞാൻ എങ്ങനെ റിയാക്ട് ചെയ്യുന്നു? അതായത് ഇന്ന് എല്ലാവർക്കും ഇപ്പോഴത്തെ പോലെ എന്നെ അങ്ങോട്ടും ഇങ്ങോട്ടും അറിയത്തില്ല. ഞാൻ കുലുങ്ങി ചിരിച്ചു. അദ്ദേഹത്തിന്റെ ഒരു റിയാക്ഷൻ ഉണ്ടായിരുന്നു, എപ്പോഴും ഓർക്കുന്നുണ്ട്. ആ സൗഹൃദം അന്നു മുതൽ ഇന്നുവരെ കീപ്പ് ചെയ്തിരുന്നു. അക്കാഡമിക് രീതിയിലെല്ലാം അദ്ദേഹം വളരെ ഗതിയിലും വ്യവസ്ഥയിലും എത്തി, സംഭാവന ചെയ്തു. അവസാനം എഡിറ്റർ ജനറലായിരുന്നപ്പോ അവാർഡ് കിട്ടിക്കാരെ പറഞ്ഞു. എന്തായാലും നമ്മുടെ ഈ സെലക്ട് ചെയ്ത ടോപ്പിക്ക് എനിക്ക് തോന്നുന്നത് ഒരു പക്ഷേ അദ്ദേഹം തന്നെ ആയിരിക്കും സജസ്റ്റ് ചെയ്തെന്ന് ഞാൻ വിചാരിക്കുന്നു. ടോപ്പിക്കും പാർട്ടിസിപ്പേഷനും എല്ലാം ഗംഭീരമായി. Keep it always. Thank you.
Thank you, Dr. Biju. It's a time for questions and answers. I think already some questions posted in the board.
There's a question from Dr. Hafiz Hassan. The question is, chat box is there in the chat box? Is the excessive or insufficient vertical dimension that causes difficulty? Can you please explain what happens in both scenarios? See, both are dangerous. Only thing, insufficient, excessive vertical dimension, we will know immediately because the patient won't be comfortable at all. Okay, the patient can't exert the masticatory force much because before the muscles activity take place, that the teeth is coming in contact, and there won't be any previous space to act. So if the vertical dimension increases, the difficulty in eating immediately you will know. But if the vertical dimension decreases, what happens? You won't be knowing. The patient will be comfortably using it, but later on, he feels that the food bolus is not being grinded properly. Does this mean the same thing happens to? I don't know who's that. Okay, some other. So this is regarding the first question. Some other questions come. Is there 2-3 times increased resorption of the posterior mandible when to see in younger age group? That is the report that has been received. In the posterior region, there will be tremendous resorption, and anteriorly, mainly mainly the resorption will be arrested because our resorption will be delayed because of the presence of implants. What causes whistling in complete denture? That is begin by Dr. Hafiz Hassan. So for the previous question, so for younger dangerous patients, it is preferable to use more implants in a spreaded manner. That means anteriorly and posteriorly you may use the implants to check the bone resorption. And for older age, if you use even just 2 implants also, it's okay. And one more has come. What causes whistling in complete dentures? That I told you. Mainly because the amount of space available for the air to flow, that will be limited. Maybe the thickness of the denture which is present in the anterior aspect. That yes, when you pronounce it sort of a whistling sound. If that space is too much, if it is less, again the S will be blurred. Another thing.
Any more questions? Please leave in the chat box.
Sir, ബീഡിങ് ആൻഡ് ബോക്സിംഗ് ഉണ്ട്. നമ്മുടെ ഈ സെക്കൻഡറി എടുത്ത് കഴിഞ്ഞിട്ട് ഫൈനൽ ഇംപ്രഷൻ എടുക്കുമ്പോൾ സാർ ആ എഡ്ജസ് കാണിച്ചല്ലോ നല്ല റൗണ്ടഡ് ആയിട്ട്. പണ്ടത് നമ്മുടെ ഗ്രീൻ സ്റ്റിക്ക് ചെയ്യുമ്പോൾ ബീഡിങ് ആൻഡ് ബോക്സിംഗ് ഒക്കെ ചെയ്യുന്ന ആൾക്കാരുണ്ടായിരുന്നു. ഇപ്പൊ അങ്ങനെ ചെയ്യുന്നില്ല. മാത്രമല്ല ഈ പട്ടി ഇംപ്രഷൻ എടുക്കുമ്പോൾ അത് പോസിബിളും അല്ലല്ലോ. അപ്പൊ സാർ കേട്ടായിരുന്നോ? Hello.
He's there.
Hello. Kekavo. Hello.
So the connection in those.
I think some problem with his connection. Yeah.
Link. Connection problem.
Pradeep, പറ. ഓ ശരി ശരി. ഓ ശരി ശരി. ഓക്കെ.
Okay, I think some power loss.
പ്രദീപിന്റെ
power problems. Yeah.
കറണ്ട് പോയി എന്ന് പറഞ്ഞ് വിളിച്ചു. ഇപ്പൊ ഫോണിൽ കൂടെ പ്രദീപ് ഇതില് കയറും.
Okay, fine. I think some more questions from the participant side.
ഏതായാലും കറണ്ട് ഇപ്പൊ പോയത് നന്നായി.
സാറ് ഇവിടെ നമ്മുടെ സ്പേസിലെ കണ്ടിരിക്കുന്നു. സുദീപ് സാർ സ്പേസിലിരിക്കുന്ന പോലെ.
അതെ, ഞാന് കുറച്ച് സ്പേസിൽ നിന്ന് തിരിച്ചിറങ്ങാൻ പറ്റിയില്ല.
അല്ല, ഇന്ന് സൺഡേ അല്ലേ, വൈഫ് വീട്ടിലുണ്ട്.
അങ്ങനെയല്ല സുദീപ് സാർ ഇപ്പൊ ഇരിക്കുന്ന ഒരു പൊസിഷൻ നിങ്ങൾ മനസ്സിലാക്കണം. അപ്പൊ എപ്പോഴും ഏറെ തന്നെയാണ് സാറ്.
സ്പേസിൽ ഇറങ്ങി രാവിലെ നോക്കി, പക്ഷെ പറ്റില്ല.
സാറ് ഇറങ്ങി വരുമ്പോ നമ്മളിവിടെ ഇറങ്ങി തന്നെ ഇരുന്ന് സംസാരിക്കും.
അതെ അതെ.
മാർക്ക് സക്കർബർഗിനൊന്നും മാത്രമല്ല സാർ, നമുക്ക് പോകാൻ പറ്റുമല്ലേ സാർ?
അല്ലാതെ ബാക്ക്ഗ്രൗണ്ട്
തിരിച്ചു വന്നു.
Okay. Yeah, he's there.
വീഡിയോ
വേറെ എന്തോ സൗണ്ട്. ഹലോ,
മക്കളുടെ ഡയറക്ഷൻ കൊടുക്കുക. നമുക്ക് ഇതിനെ പറ്റി അറിഞ്ഞൂടല്ലോ, പിള്ളേർക്കല്ലേ ഇതിനെപ്പറ്റി ഡീറ്റെയിൽസ് അറിയാം. അതിന്റെ ചിരിക്കുന്നത് അതിനെ വിചാരിക്കും ഈ സാർ ഇവർക്കൊന്നും ഒരു ഐഡിയ ഇല്ല എന്ന് വിചാരിക്കും. ഇല്ല, അങ്ങനെ പാവം.
Some more questions are there, no?
Pradeep sir, clear.
He joined.
Pradeep sir വന്നോ? ക്ലിയർ ആയില്ലല്ലോ.
Clear അല്ലാന്ന് തോന്നുന്നു.
അല്ല.
Yeah, he's there. Kindly unmute your audio.
ഓഡിയോ അൺമ്യൂട്ട് ആണ്, പക്ഷെ കേൾക്കുന്നില്ല.
അല്ല,
അല്ലേ?
ഓഡിയോ അൺമ്യൂട്ട് അല്ല.
സ്റ്റക്കായോ?
Yeah, he's there. Yeah. Yeah, Dr. Pradeep, Dathan, you can interact with us. Hello.
കവറേജ് പ്രശ്നമാണോ?
നെറ്റ്വർക്ക് കംപ്ലൈന്റ് ആണെന്ന് തോന്നുന്നു.
Yeah, he's there. Some network problem, I think.
Yeah.
പ്രതിഭ കേൾക്കാമോ? ഇവിടെ നെറ്റ്വർക്കിന്റെ പ്രശ്നം എന്തോ ഉണ്ട്.
അദ്ദേഹത്തിന്റെ മകള് സഹായിക്കാൻ എത്തിയിട്ടുണ്ടെന്ന് തോന്നുന്നു.
പ്രോസ്തോ മാസ്റ്റർ വേറൊരാൾ ഇരിപ്പുണ്ട്. എന്നാ പിന്നെ അദ്ദേഹത്തോട് ആയാലോ സംശയം?
ഓ, ചോദിച്ചോ. എന്താ പറഞ്ഞു എന്ത്? അല്ല, അഭിലാഷ്
ബീഡിംഗ് ആൻഡ് ബോക്സിനെ കുറിച്ചാണ് ചോദിച്ചത്. ബീഡിംഗ് ആൻഡ് ബോക്സിനെ കുറിച്ചാണ് സാർ ചോദിച്ചത്. ഫൈനൽ ഇംപ്രഷൻ എടുക്കുമ്പോ പണ്ട് ഗ്രീൻ സ്റ്റിക്കിലാകുമ്പോ ചെയ്ത് നമ്മൾ ആ എഡ്ജസ് നല്ല റൗണ്ടഡാക്കി എടുക്കുമായിരുന്നല്ലോ. ഇപ്പം നമ്മൾ സിലിക്കോൺ പൊട്ടി വെച്ച് നമ്മൾ ചെയ്യുമ്പോ ബീഡിംഗ് ആൻഡ് ബോക്സിങ് ചെയ്യാൻ ആ രീതി പറ്റത്തില്ലല്ലോ. അതായിരുന്നു എന്റെ സംശയം.
അല്ല, ബീഡിംഗ് ആൻഡ് ബോക്സിങ് സിലിക്കോൺ പട്ടി വെച്ച് ചെയ്യാം. ഒരു കുഴപ്പമില്ല. അത് ബേസിക്കലി ലാൻഡ് ഏരിയ കിട്ടാൻ വേണ്ടിയിട്ടാണ് നമ്മൾ ബീഡിംഗ് ആൻഡ് ബോക്സിങ് ചെയ്യുന്നത്. അപ്പൊ ലാൻഡ് ഏരിയ ഇമ്പോർട്ടന്റ് ആണ്. ബിക്കോസ് ഒരു ഡെഞ്ചറിന് ബോർഡേഴ്സ് ആണ്. ബോർഡേഴ്സ് എന്ന് പറഞ്ഞാൽ 3 ഡയമെൻഷണൽ ബോർഡർ ആണ്. ഡെപ്തും ഉണ്ട്, വിഡ്ത്തും ഉണ്ട്. ഡെപ്തും വിഡ്ത്തും കിട്ടണമെന്നുണ്ടെങ്കിൽ ഡെപ്തും വിഡ്ത്തും കിട്ടണം.
ലാൻഡ് ഏരിയയുടെ വിട്ട് കിട്ടണമെങ്കിൽ ബീഡിങ് ആൻഡ് ബോക്സിങ് ചെയ്താലേ അത്രയും വിട്ട് കിട്ടുള്ളൂ. അതെ,
എന്നുവെച്ചാൽ നമ്മൾ പലതും ഈ വിട്ട് പലരും കോംപ്രമൈസ് ചെയ്യാറുണ്ട്. നമ്മൾ ഈ ട്രിം ചെയ്യുമ്പോഴും പോളിഷ് ചെയ്യുമ്പോഴും ഒക്കെ വിട്ട് ചിലപ്പോ നശിക്കും. പക്ഷെ ഡെപ്ത് കറക്റ്റ് ആയിരിക്കും. ചിലപ്പോ ഈ കാസ്റ്റില് ഉള്ള പോലത്തെ ഡെപ്തും വിട്ടും കിട്ടണമെന്നുണ്ടെങ്കിൽ ലാൻഡ് ഏരിയ എന്ന് വെച്ചാൽ അത് കഴിഞ്ഞിട്ടുള്ളൊരു ഏരിയ ഉണ്ട്, അതാണ് ലാൻഡ് ഏരിയ. ലാൻഡ് ഏരിയ കറക്റ്റ് ആയിരിക്കും.
അതെ അതെ.
ഇല്ലെങ്കിൽ വിട്ട് കറക്റ്റ് ആവത്തില്ല. വിട്ട് കറക്റ്റ് അല്ലെങ്കിൽ സീല് കറക്റ്റ് ആവത്തില്ല.
നമ്മൾ മറ്റത് വാക്സ് വെച്ചും ചെയ്യുമായിരുന്നല്ലോ.
നിർബന്ധമാണ്.
ഗ്രീൻ സ്റ്റിക്കിൽ നമ്മൾ
വാക്സ് വെച്ച് ചെയ്യുമായിരുന്നു. പക്ഷെ ഇപ്പൊ മെറ്റീരിയൽ ഞാൻ പറഞ്ഞുതരാം. വാക്സ് വെച്ചിട്ട് നേരത്തെ ചെയ്യുമായിരുന്നു. ഇപ്പൊ എങ്ങനെ പട്ടിയിലാണെങ്കിൽ എങ്ങനെ ചെയ്യാമെന്ന്.
പട്ടിയിലാണെങ്കിൽ നമുക്ക് എങ്ങനെ ചെയ്യാം?
പട്ടിയിലാണെങ്കിൽ സിലിക്കൺ വെച്ചിട്ട് നമുക്ക് ബീഡിങ് ആൻഡ് ബോക്സിങ് ചെയ്യാം. ബോക്സിംഗ് വേണമെന്നില്ല, ബീഡിങ് ചെയ്താൽ മതി. ബീഡിങ് ചെയ്തിട്ട് പിന്നെ ബോക്സിംഗ് വാക്സ് വെച്ച് ചെയ്താൽ മതി.
പട്ടി മെറ്റീരിയൽ വെച്ച് ചെയ്താൽ മതി.
പട്ടി മെറ്റീരിയൽ വെച്ച് ചെയ്താൽ മതി. ഇപ്പൊ അഡീഷണൽ സിലിക്കോൺ ഉണ്ട്. കണ്ടൻസേഷൻ യൂസ് ചെയ്യാം, ചീപ്പാണ്. കണ്ടൻസേഷൻ മറ്റേതിൽ യൂസ് ചെയ്യത്തില്ല, പെർമനന്റ് ഇംപ്രഷൻസ് യൂസ് ചെയ്യാം. ഇതിൽ യൂസ് ചെയ്യാം.
നമുക്ക് സാറ് പറഞ്ഞ
കിട്ടണമെന്നുണ്ടെങ്കിൽ അതെ, ഷാർപ്പായിട്ട് വരാൻ പാടില്ല. ഷാർപ്പായിട്ട് വരുമ്പോഴത്തേക്ക് അവിടെ ഇതേപോലെ നേരത്തെ പ്രദീപ് പറഞ്ഞ പോലെയുള്ള പ്രോബ്ലംസും അങ്ങനെയൊക്കെയുള്ള ഇഷ്യൂസ് വരും. പ്രദീപ് വന്നു തോന്നുന്നു. Pradeep?
He joined, but some connection issues. Unmute ആക്കാനൊന്ന് പറയൂ.
Unmute ചെയ്യ് പ്രദീപ്.
Dr. Anil, can you just call him?
Just
tell him to unmute it. Yeah.
Unmute ചെയ്യാൻ പറയൂ. വിളിച്ച് പറഞ്ഞു. അപ്പൊ പ്രദീപിന് ക്യാമറയിൽ നമ്മളെ കാണാൻ, പക്ഷെ സംസാരിക്കുന്നൊന്നും കേട്ടൂടാ.
അത് തന്നെ അൺമ്യൂട്ട് ചെയ്യാൻ പറഞ്ഞാൽ മതി.
അല്ലെ പ്രദീപ് ക്യാമറ ഓഫ് ചെയ്യോ? എനിക്ക് ഒന്ന് റേഞ്ച് കുറവാണെങ്കിൽ ക്യാമറ ഓഫ് ചെയ്താൽ സൗണ്ട് മാത്രം കിട്ടും.
ശരി ശരി.
രണ്ടും കൂടെ ആവുമ്പോ ബാൻഡ് വിഡ്ത്ത്, ബ്രാൻഡ് അല്ല ബാൻഡ് വിഡ്ത്ത്. സാറേ പുള്ളി വരുന്ന ഒരു ചോദ്യം, സുദീപ് സാറേ പുള്ളി വരുന്ന ഒരു സംശയം കൂടെ ചോദിച്ചോട്ടെ. നമ്മുടെ മാക്സിലറി ട്യൂബറോസിറ്റി ഭയങ്കര ബൾബസ് ആയിരിക്കുന്ന കേസുകൾ, അതായത് ഇങ്ങനെ വലിയ ഉണ്ട പോലെ ഇരിക്കുന്നു കണ്ടിട്ടുണ്ടല്ലോ, അവിടെ ഭയങ്കര ഡീപ്പ് അണ്ടർകട്ട് വരാറുണ്ട് നമ്മൾ എടുക്കുമ്പോ. അവിടെ ഡെൻചർ ഇങ്ങനെ ഒരു കുഴിങ്ങനാക്കി തരും, സോ കേറില്ല ഡെൻചർ. അപ്പം എന്റെ സംശയം, അങ്ങനെയുള്ള ട്യൂബറോസിറ്റിയിൽ നമ്മൾ ആൽവിയോപ്ലാസ്റ്റി ചെയ്തിട്ട് ഇംപ്രഷൻ എടുക്കണോ, ആ ഒരു
ബൈലാറ്ററൽ ആണെങ്കിൽ രണ്ട് സൈഡിലും അങ്ങനെ ബൾബസ് ആയിട്ട് നിൽക്കുകയാണെങ്കിൽ ചെയ്തിട്ട് ചെയ്യാൻ നല്ലത്. ഇല്ലെങ്കിൽ മുറിയും ഭയങ്കര പെയിൻഫുൾ ആയിരിക്കും,
ഭയങ്കര ബുദ്ധിമുട്ടാണ്. ആ ഡെൻചർ ഭയങ്കരമായിട്ട് ഇൻസേർഷൻ ഏറ്റവും ഭയങ്കര കോംപ്ലിക്കേഷനുമാണ്. തിരിച്ചത് ഭയങ്കരമായിട്ട് ആ സ്കിൻ മുഴുവൻ ഇതായിട്ട് തിരിച്ചു വരും പേഷ്യന്റ്, നമ്മൾ എങ്ങനെയെങ്കിലും ട്രീറ്റ് ചെയ്താലും. അപ്പൊ അത് AP ചെയ്തിട്ട് ചെയ്യുന്നതായിരിക്കും നല്ലത് അല്ലേ?
അതെ അതെ. മൗത്ത് പ്രിപ്പറേഷൻ
കൂടുതലും ബൈലാറ്ററൽ ആയിട്ടാണ് അത് കാണുന്നത്. ഒരു സൈഡ്
ബൈലാറ്ററൽ ആണെങ്കിൽ ചെയ്യാൻ നല്ലത്. ഇല്ലെങ്കിൽ നമുക്ക് അതും കൂടെ കവർ ചെയ്ത് എടുത്തതിന് ശേഷം പിന്നെ സോഫ്റ്റ് ലൈനർ ഒക്കെ ഇട്ട് നമുക്ക് വേണമെങ്കിൽ ശരിയാക്കി എടുക്കാം.
ആ ഭാഗത്ത് അണ്ടർകട്ട് ഭാഗം ഇത് കട്ട് ചെയ്ത്
അണ്ടർകട്ട് ഭാഗം സോഫ്റ്റ് ലൈനർ ഒക്കെ ഇട്ട് കുറച്ചൊക്കെ ശരിയാക്കാം.
നമ്മൾ ഒരുപാട് കട്ട് ചെയ്ത് സക്ഷനിൽ കിട്ടത്തില്ല, അതാണ് വേറൊരു പ്രശ്നം.
ഹലോ സുദീപ്, ഒരു മിനിറ്റ്. പ്രദീപിന്റെ സൗണ്ട് ഇപ്പൊ കേൾക്കാമോ? അതിലുണ്ടോ പ്രദീപിന്റെ കണക്ഷൻ?
പ്രദീപ് കേൾക്കാമോ?
അദ്ദേഹത്തിന്റെ സൗണ്ട്
വരുന്നില്ല.
കേട്ടില്ല. ഇല്ല. ശരി ശരി, ഓക്കെ.
അങ്ങനെ ബൈലാറ്ററൽ ആയിട്ടുള്ളത് എപ്പോഴും നമ്മൾ അതൊന്ന് കറക്റ്റ് ചെയ്തിട്ട് ചെയ്യുന്നതാണ് നല്ലത്. ഇല്ലെങ്കിൽ ഭയങ്കര പെയിൻഫുൾ ആയിരിക്കും.
അതാണ് ഡെൻചർ. ഒത്തിരി കേസുകൾ അങ്ങനെ നമ്മൾ ബുദ്ധിമുട്ടിയിട്ടുണ്ട്.
ഈ ഒരു ഇത് ലോവറിലും വരാം, ഇതുപോലെ അണ്ടർകട്ട് വരാം.
അപ്പൊ അത് പരമാവധി ആന്റീരിയർ റീജിയനിലെല്ലാം, കനിയൻ റീജിയനിലെല്ലാം ഭയങ്കര തിക്കായിട്ട് നിന്നിട്ട്
ബൾബസ് ആയിട്ട് വരാം. അതൊക്കെ മൗത്ത് പ്രിപ്പയർ ഒരു ഇതേ ആൽവിയോപ്ലാസ്റ്റി പോലെ എന്തെങ്കിലുമൊക്കെ ചെയ്ത് ചെയ്യുന്നതാണ് നല്ലത്. കുറച്ചുകൂടെ ചെയ്യുമ്പോ ഒരു പ്രശ്നം, എക്സ്റ്റെൻസീവ് ആയിട്ട് ചെയ്യരുത്, റിസോപ്ഷൻ കൂടും, പിന്നെ അവസാനം ഇത് കാണത്തില്ല, ഡെൻചർ ഇരിക്കാൻ സ്ഥലം കാണൂല.
ഈ ഫ്രീനൽ അറ്റാച്ച്മെന്റ് ഡീപ്പായിട്ടുള്ളിടത്ത് നമ്മൾ മാക്സിമം റിലീഫ് ഡോക്ടർ നേരത്തെ പറഞ്ഞു തിന്നായിട്ട് കൊടുക്കാൻ പറഞ്ഞു, ബ്രോഡ് ആക്കാതെ. എന്നാൽ പോലും ഡീപ്പായിട്ട് കൊടുത്തു കഴിഞ്ഞാൽ ഒരു ഫ്രാക്ചർ ലൈൻ വരുന്ന കേസുകളുണ്ട്. എന്നാൽ കൊടുക്കാതിരുന്ന ഫ്രീനം മുറിയും ചെയ്യും. അപ്പൊ നമുക്ക് എന്ത് ചെയ്യാം?
അല്ല, ഇപ്പൊ ഫ്രീന ഉള്ള സ്ഥലത്ത് നമ്മൾ അല്ലെങ്കിൽ ഫ്രീനൽ എന്തെങ്കിലും അറ്റാച്ച്മെന്റ്
മാറ്റുക എന്നുള്ളതാണ്. ഫ്രീനെക്ടമി ചെയ്തിട്ട് ചെയ്യായിരിക്കും.
ഒരു പരിധി വരെ
പലപ്പോഴും ഈ ടിപ്പിൽ വരുന്ന ഫ്രീനം അതിനത്രയും
ഫ്രീനൽ അറ്റാച്ച്മെന്റ്
മാറ്റുന്നതായിരിക്കും.
കേക്കാം.
ഒരു ഫോണിൽ നിന്ന് കയറിയപ്പോ ശരിയായില്ല, പിന്നെ വേറെ എന്റെ ഭാര്യയുടെ ഫോൺ വാങ്ങിച്ച് അതിൽ നിന്നാണ് കയറിയേക്കുന്നത്. ഇവിടെ കറണ്ട് പോയി. നമ്മുടെ ലാസ്റ്റ് സ്ലൈഡ് കാണിച്ചപ്പോ അവിടെ ഏതാണ്ട് സാധനം ഷോർട്ടായി, കറണ്ട് അങ്ങ് പോയി. ഓക്കെ,
ഒരു ക്വസ്റ്റ്യൻ കൂടെ ഉണ്ട്. വാട്ട് ഇസ് ദ റോൾ ഓഫ് പാലറ്റ് ഇൻ ടേസ്റ്റ് സെൻസേഷൻ? What is
role of palate in taste sensation? See, palate has a lot of minor taste buds, a lot of taste buds. Okay, that will be covered by the denture. മനസ്സിലായില്ലേ? ഒരുപാട് taste buds are present on the palate. So once the tongue touches the palate, you will feel that. The taste you will feel. That complete taste buds will be covered by the maxillary denture. That is the role. The whatever taste buds present in the soft palate region, the palatal region will be covered by the denture. That is why the palate. That is the role. Anything else?
Any other questions?
ഫ്ലെക്സിബിൾ ഡെഞ്ചേഴ്സിനെ കുറിച്ച് ഇപ്പൊ പല ലാബുകാരും ഫ്ലെക്സിബിൾ ഡെഞ്ചേഴ്സ് VPS ഇങ്ങനെ പല മെറ്റീരിയൽസ് ഇറക്കിയിട്ടുണ്ട്. ഇപ്പൊ ഭയങ്കര റേറ്റുമാണ്.
Flexible dentures actually, when it comes to complete denture, flexible denture is good for removable partials because it maintains its flexibility and it adapts well. But when it comes to complete denture, it is no more flexible. It is almost equal to your conventional acrylic dentures. Only thing, it has got more adaptation. Just got more adaptation because they are using an injection molding technique, so it has got more adaptation. But that flexibility won't be there because buccally and lingually you have an attachment. A denture base ഉണ്ട്, അതുകൊണ്ട് flexible ആയിരിക്കത്തില്ല. But
undercut ഉണ്ടെങ്കിൽ വേണമെങ്കിൽ
because of injection molding, it has got very good adaptation. അതാണ് സക്സസ്. കേട്ടില്ല?
undercut
somebody asked something, I could not hear.
അത് സുദീപ് സാർ പറഞ്ഞു. അത് വീണ്ടും വോയിസ് പോകുന്നു.
ഇതല്ലേ ചോദിച്ചേ?
സാറിന്റെ വോയിസ് പിന്നെയും പോയി.
ഹലോ
ഹലോ. ഇപ്പൊ ഇടയ്ക്കിടയ്ക്ക് മുറിഞ്ഞു പോകുന്നുണ്ട്.
ഹലോ
ഹലോ, കേൾക്കുന്നുണ്ട്. ഇടയ്ക്കിടയ്ക്ക് സൗണ്ട് മുറിഞ്ഞു പോകുന്നുണ്ട്. ക്ലാരിറ്റി ഇല്ല.
ഡൗട്ട്സ് കഴിഞ്ഞില്ലേ?
വൈൻഡപ്പ് ചെയ്യാലോ അല്ലേ പ്രസിഡന്റ്?
യെസ്,
കുഴപ്പമില്ല. ഏതാണ്ട്
ആയല്ലോ. ഓക്കെ,
ശരി. ഓക്കെ, ശരി ശരി.
ഇല്ല,
എന്റെ മൊബൈൽ ഇല്ല, അതുകൊണ്ട്
എന്നെ കാണാവോ അതില്?
കാണാൻ പറ്റും.
ശരി.
ഇടയ്ക്ക് വോയിസ് കട്ടാവുന്നു. ഓക്കെ,
പ്രസിഡന്റ് കേൾക്കുന്നില്ല. നോട്ട് ഓഡിബിൾ. പ്ലീസ് അൺമ്യൂട്ട്.
പ്രസിഡന്റ് അൺമ്യൂട്ട് ചെയ്യ്.
Yeah, hi.
Yes.
If any more doubts, let the participants to come to the WhatsApp group and Dr. Pradeep will discuss with them. So,
yes.
Shall we wind?
Yes.
Oh, yeah. Okay. Yeah, thank you.
Dr. Anil Kumar, for the vote of thanks. നമ്മുടെ ബ്രാഞ്ചിൽ ആദ്യമായിട്ട് സോൾട്ട് ആൻഡ് പെപ്പർ ഇൻട്രൊഡ്യൂസ് ചെയ്ത മനുഷ്യനാണ്. ഇപ്പൊ പെപ്പർ ഇല്ല, സോൾട്ട് മാത്രമേ ഉള്ളൂ. So I invite Dr. Anil Kumar for delivering the vote of thanks.
വളരെ നല്ല ക്ലാസ് ആയിരുന്നു. നല്ല അഭിപ്രായം പറയണമെന്ന് വിചാരിച്ചു, പക്ഷെ എനിക്ക് അവസരം കിട്ടിയില്ല. എല്ലാവരും നല്ല അഭിപ്രായം ആദ്യമേ പറഞ്ഞതുകൊണ്ട് ഞാൻ ആ ഒരു പാർട്ട് ഒഴിവാക്കുകയാണ്. ഡയറക്റ്റ് ആയിട്ട് ഓട്ടോ താങ്ക്സിലോട്ട് പോകുന്നു. ഓൺ ബിഹാഫ് ഓഫ് ഐഡിയ ആറ്റിങ്ങൽ ബ്രാഞ്ച്, ഐ താങ്ക് Dr. Pradeep for his excellent presentation, and I thank our participants who attended this program and make it a grand success. And I would like to thank Dr. Our CD convener, Dr. Adina, for conducting this program, and Dr. Arunas for giving all support to her. Thank you. Thank you all.
Thank you very much, Dr. Anil. Yeah.
Program ആയിട്ട് നമുക്ക് വീണ്ടും കാണാം.
Yeah. So Adina, Tata, Secretary, our senior most members, Dr. Pradeep.
Bye.
Adina, yeah.
ഫാക്കൽറ്റിയെ വിളിച്ചത് ഒന്ന് കേൾക്കാൻ പറ്റുന്നില്ല, നന്ദി സ്വീകരിച്ചു എന്ന് പറയാൻ പറഞ്ഞു.
Yeah. If any doubts, the participants can post in our WhatsApp group. He can interact with them.
Yes.
Okay,
Please leave
thank
the doubts in the WhatsApp group.
Yeah. Leave the meeting. Thank you all.
Okay. Bye.
Bye.